Thank you very much for your introduction. Good morning, everybody. And first of all, I would like to thank the organizers for inviting me here to be here today to this very interesting conference. So it's a great pleasure and honor to be here today and to talk about mental health, metabolic factors, and diabetes. So I would like to give a brief introduction into the topic. And in the first part, I would like to talk about depression, metabolic risk factors, and risk of diabetes. Second part, depression and blood glucose. So what is the role of metabolic factors? What is the role of behavioral factors? How they're linked, associated with each other. And metabolic risk factors, depression, and I would continue with connect to the previous talk, so with cognitive functioning. So what is the link? What do we know about associations based on longitudinal studies? So today I would like take an epidemiological perspective, so I will not present so much individual patient data or clinical data, so I would like to take the public health and epidemiological perspective. This one. Okay, so depression and metabolic risk factors, is there a link? So we know there's some association between depression, mental health, and diabetes, and I think we will, in the next talk, we'll focus more on depression and diabetes. But there's also some association between depression and metabolic risk factor, metabolic syndrome. So when we look at the literature, a lot of studies, individual studies have focused on individual components, on hypertension, obesity, depression. So there are well-established links, and I think one key paper was published in 2012 by Pan et al. About bidirectional associations between depression and metabolic syndrome. So they did a systematic review and meta-analysis of epidemiological studies to see what is the link between depression and metabolic syndrome. So what I've found, sorry, it's still. So this is the first slide. So I looked at the association metabolic syndrome as a predicting risk of future depression. So there was a 50% increased risk. Those with metabolic syndrome had a 50% increased risk of developing depression based on the evidence from studies here. And for the other direction, depression predicting future risk of the metabolic syndrome. So there was also a 50% increased risk for the other direction. So it was, at least I concluded, there was a lot of evidence that depression and metabolic syndrome are associated with each other in a bidirectional way. So both of them increase the occurrence of the other one based on the epidemiological study. So this was published in 2012, and a couple of other systematic reviews and meta-analysis have been published afterwards, and most of them support the idea that there's a link, a bidirectional association between the two conditions. So then we're interested, so depression, metabolic risk factors, and how do they work together, and how they're linked with each other, and how do they increase the risk of developing diabetes. So there's some evidence or some ideas, or we know that metabolic dysregulation is an important risk factor for type 2 diabetes. So people with metabolic problems have an increased risk of developing diabetes. There's evidence from the literature on depression. Depression increases the risk of developing diabetes, but probably there might be some link, some interaction between the two groups. So what is called, has been called in the literature as metabolic depression. So people suffering from both conditions, depression and metabolic dysregulation, so those people might be at a higher risk of developing type 2 diabetes. So this term metabolic depression is getting a lot of attention right now. It was introduced several years ago by a Dutch group like Vogelsangs and Martin's group and other people. So this idea that having two conditions, metabolic dysregulation and depression at the same time, might be associated with an increased risk for health outcomes, including diabetes and some other health outcomes. So we were interested in a study, to do a study to see, to identify the association between depressive symptoms, metabolic dysregulation, and incidence of type 2 diabetes. So we need a long follow-up. So what's the idea? How can we do this? Doing a study where we have information about both depression and metabolic dysregulation and incidence of diabetes. So this was the idea to team up with the Cartagena study in Montreal, in Quebec. So you might have heard about Cartagena study. It was a community-based study that started in 2008, 2009 was the first wave. There was a second wave 4 years later, again, additional 20,000. And I just finished follow-up assessments of those people. But here I focus on the first cohort, which were recruited in 2008, 2009. So we had a sample of 20,000 adults in Quebec, aged 49 to 69, so in the mid-age, and people were sampled from the REMQ database, so from the administrative database, and participants were invited for a health interview, and blood samples were taken, physiological measurements were taken, and there were 4 study centers, 4 sites where people were recruited, and at the same time there was a long interview. It was a 2 or 3 hours interview about health conditions, general health, and family history, and mental health, and a lot of other conditions. So we teamed up with this Cartagena and said, okay, we're interested in people with depression, people with metabolic dysregulation, and people with both conditions, and would like to do a follow-up of those people to see what is the risk of developing diabetes. So we started a study where we recruited a subsample of 2,500 individuals out of the Cartagena group, where we had information about depression and metabolic symptoms, and a clinical interview for depression and diabetes incidence. So it sounds now, when we look back, it looks very easy doing a follow-up assessment of an existing cohort, but at this time it was really complicated. We had 4 or 5 different ethics boards involved in order to get contact to people and to invite them for follow-up assessment. So what we did, we had a stratified sample at the end. Sorry about the slides, it seems to shift it away. But we had four different groups. We had one group which was our control group, 760 people with no depression and no metabolic problems. One group with depression and no metabolic problems. One group with no metabolic problems, with depression and no metabolic problems, and one group with depression and metabolic problems. So diabetes incidence for the 4 depression metabolic subgroups was our main interest. So after adjusting for other factors that might be relevant or might confound some of the association, including age, sex, education, ethnicity, family history of diabetes, smoking, diet, and physical activity. And we were interested, so what is the interaction? Is there an effect? Is there an additive effect? Is there more than an additive effect? And in a second step, we used some more complex modeling, taking into account that we had different information for depression. So we used depression measured by a questionnaire, depression measured based on a CD interview, and antidepressant medication as indicator for depression. So what we had after 5 years was the mean follow-up time. So we had 87 individuals developed diabetes between baseline and follow-up. So when you compare the 2 groups, there was no much difference between age. Those who developed diabetes had at baseline a higher depressive PHQ-9 score, depressive symptoms 6.6 compared to 4.6. And as one might expect, those people had a higher prevalence of metabolic risk factors at baseline: hypertension, impaired glycemic control, HDL, triglycerides, and central obesity were much higher in this group. So when we looked at the association between the different groups and the risk for diabetes onset, so we used the group without depressive symptoms and without metabolic problems as a reference group. So when we look at the group with metabolic dysregulation without depressive symptoms, so there was an odds ratio of 4.4. So as expected, based on the literature, substantial association between metabolic dysregulation and onset of diabetes in this aging cohort. So when we looked at depressive symptoms and no metabolic dysregulation, so we see it was an odds ratio of 1.2, but 0.8 to 2.0 confidence interval, so suggesting depression without metabolic dysregulation here was not associated with the onset of diabetes. And when we looked at the group of depressive symptoms and metabolic dysregulation, so we had an odds ratio of 6.6, so indicating a very strong association for those with depressive symptoms and metabolic problems. So the question is this different? 6.6, is it different compared to those with metabolic dysregulation without depressive symptoms? So meaning, is there an additive effect? Is there more than an additive effect? And we use the synergy index, often used in epidemiology, to see if the effect is additive or if it's more than additive. And we had a synergy index here of 1.5, suggesting that the combined effect of depressive symptoms and metabolic dysregulation is greater than the sum of the individual effects. So it seems probably something is going on here when people have both conditions, depression and metabolic problems, which increase the risk of developing diabetes. So as I said, we did some more complex modeling using depression as a latent variable and metabolic dysregulation as a latent variable. So it's a busy slide. I will not go into the details, just to show you. So for depression, we used depressive medication, PHQ-9 scores, major depression history based on CD interviews, and we looked at the interaction and found still an important association between interaction between depression and metabolic dysregulation and diabetes incidence. So to summarize, individuals with both depressive symptoms and metabolic problems at baseline were at higher risk for developing type 2 diabetes, and it's probably more than an additive effect. So how can we explain this, or what is the association between those conditions? So we know lifestyle, as we've heard before, lifestyle is not only important for dementia, it's important for so many other conditions. So lifestyle, diet, physical activity, smoking, alcohol is associated with metabolic dysregulation, but those conditions are associated with depression too, and so lifestyle or health behaviors might be an important pathway how depression and metabolic dysregulation are connected with each other. So poor lifestyle increase risk of metabolic dysregulation, which increase the risk of depression, which again increase associated with poor lifestyle. So there might be an important dynamic association between metabolic dysregulation and depression based on lifestyle behaviors. But there are other factors. There are disease-related factors that might be important. Drug therapy, so antidepressant medication associated, at least for some of the drugs, associated with weight gain and potential metabolic dysregulation, sleep problems, obesity, chronic stress. Those are all factors known from the literature associated with metabolic dysregulation, but those factors also associated with depression, and there might be another pathway here with this disease-related factors. And for sure, there might be biological factors, inflammation, as we heard before, very important, HPA axis, sympathetic nervous system regulation, CNS regulation. And so there are different potential pathways, and it's very likely there's not only one direction, it's very likely that different pathways are working at the same time. So it's not sufficient to focus only on one way. I think there are a lot of different potential pathways working simultaneously at the same time. So one conclusion of this early identification, monitoring and comprehensive management approach of both conditions might be an important diabetes prevention strategy. So you might not say, oh, this was a nice study based on the CATA gene, but you had 90 people who developed diabetes, so can you really draw any strong conclusion about interaction between metabolic factors and diabetes. So we took the study as a first step, and we worked with international teams, UK and Netherlands and US, and tried to replicate the findings. And what we see is that we can replicate this idea of metabolic depression, that metabolic depression is associated with an increased risk of developing diabetes. So we replicate our findings in the English longitudinal study on aging, in the Whitehall 2 study, in the Rotterdam study, and we will come up with a short, with a very brief meta-analysis where we summarize the results, but their main findings. So we were able to replicate these findings, and this seems to be an important interaction between depression and metabolic conditions. So I talked about depression, so you might ask, what about the other factors? What about anxiety? And it's very likely, here we focus on depression, but it's very likely that other factors are involved too, like anxiety or other mental conditions. So here in this study, we had a chance to look at risk of diabetes among a subsample with pre-diabetes at baseline. So we focused, we're interested, so is anxiety different than depression? Do we get the same results? And here we focus on a subsample with pre-diabetes at baseline. And so what we see, we compute odds ratios adjusted for potential confounders. So what we see if when we have people with pre-diabetes and high depression, so there's an increased risk of developing diabetes compared to those with pre-diabetes with low depression, so an odds ratio of 2.8. And when we look at anxiety symptoms, so we only had symptoms here based on the GAD. We had no clinical interview for anxiety. But if you use anxiety symptoms, so people with pre-diabetes and high anxiety, odds ratio was very similar, 2.4 increased risk of developing diabetes compared to those with pre-diabetes and low anxiety. So it's probably not unique, this association not unique to depression. It might be similar for anxiety and other conditions, and maybe it's not so much a depression-specific condition. It could be a general mental factor or general psychological or stress-related factor. Okay, so then we have this association between metabolic factors and depression. And so next step we're interested depression and blood glucose. So what is the association between two conditions, and what is the potential role of metabolic and behavioral factors in this association? So there's a lot of evidence that both biological factors might play an important role, from depression to diabetes and diabetes to depression, and behavioral factors might be an important role. But here in this study, we were interested going a step back, so not looking at the diabetes, yes, no, but looking at the blood glucose, HbA1c levels, and depressive symptoms in a longitudinal study. So what is the association over time between HbA1c levels and depression? So we were working with the English longitudinal study of aging in the UK, ELSA study, which is to evaluate the dynamic relationship between depressive symptoms and HbA1c levels over time. So the ELSA study is an still ongoing national longitudinal study of adults aged 50 years and older in the UK, started in 2002. So participants were reassessed or are reassessed every 2 years, and every 4 years as a blood sample taken. And so for this study here, we focused on 3 repeated assessment over 8 years time interval, where we had almost 3,000 participants in 3 clinical assessments. So measures at the depression scale, the 8-item CSD scale. It was a clinical assessment, so with information on BMI, blood pressure, diet, smoking, lifestyle-related behaviors, and blood samples were taken, so that we had information about HbA1c levels and some other biological parameters. So in the first step, we were interested, so what is the temporal relationship over time between depressive symptoms and HbA1c levels? So do depressive symptoms at one time point, here at wave 2, predict HbA1c levels 4 years later, and do HbA1c levels predict depressive symptoms additional 4 years later? So what is the dynamic temporal relationship between those conditions over time, while controlling for other potentially confounding factors on this association? So depression here was modeled as a latent variable based on the individual symptoms. So then the second step, see if there's an association, and which we know expected from the literature. So how can we explain this association? So what is, how those two factors are linked, how HbA1c levels and depressive symptoms are linked with each other? So other associated through lifestyle, is this association explained by lifestyle-related behaviors like diet, smoking, alcohol consumption, physical activity, metabolic status, blood pressure, triglyceride, inflammation, HDL, BMI. So is there still association once we include those potential mediating factors, or those metabolic factors and lifestyle factors explain or mediate the association between HbA1c levels and the depressive symptoms, and same for the other direction, from depressive symptoms to HbA1c levels. So results from the study were aging cohort, so mean age at baseline was 63 years, and there were 8 years of follow-up. So what we expect was cohort smoking 13%, physical inactive 20%. So in the first step, when we looked at the temporal relationship, so as expected, depressive symptoms at one time point is a very strong predictor for depressive symptoms 4 years later. So we know one depressive episode increases the risk of another depressive episode. So not surprising. Same for HbA1c levels. HbA1c level at one time point is a predictor for HbA1c level at the next time point 4 years later. So very strong correlation over time association. But what we see then is depressive symptoms at one time point were a predictor for HbA1c levels 4 years later, and HbA1c levels at one time point were a predictor for depressive symptoms 4 years later. So associations are not very strong. They're significant, but not very strong, but it seems there's some kind of association. And we have to keep in mind that we had a very general measure of depression here, the 8-item. It's a binary tool, 8-item scale for depressive symptoms. So it's a very global measure of depressive symptoms, and there might be some stronger associations if we use more comprehensive tools or instruments. So then we're interested in the potential mediation. So is the association between the two conditions explained by lifestyle and metabolic status? So what we see is HbA1c levels at one time point predict lifestyle behaviors, which in turn predicts depressive symptoms, and HbA1c levels also predict metabolic status and depressive symptoms later on. So it seems that lifestyle-related behavior and metabolic status explain partially the association between HbA1c and depressive symptoms. So there was no direct effect anymore. So this dotted line was not, association was very weak. So which means that the link between those two conditions is mostly explained by lifestyle-related and metabolic status. But there might be some other factors, genetic factors too, which might explain association. And a very similar association for the other direction, from depressive symptoms to HbA1c level. Depressive symptoms predict lifestyle and HbA1c level, and same for metabolic status and HbA1c levels. So to summarize from this study, published in Psychological Medicine in 2016, so depressive symptoms at baseline were associated with HbA1c levels at the follow-up, which in turn was associated with depressive symptoms at the next follow-up wave, and cardiometabolic factors and lifestyle-related behaviors might mediate this dynamic association between depressive symptoms and blood glucose levels. So again, what is the interpretation? And there are very likely several ways, several pathways that are included in this association. So from the pathway depressive symptoms to HbA1c levels, behavioral factors, as we heard now a couple of times, are very important and might be one explanation. Antidepressant treatment, genetic factors, biological factors, chronic stress might be an important factor. Increased inflammation might be associated in this pathway. For the other direction, from HbA1c level to depression, it's a little bit more difficult or more tricky. Probably, at least for those with prediabetes or diabetes, so the condition itself might be a risk for depression. So perception of disability, awareness of a chronic illness, psychosocial burden, and realizing the loss of healthy functioning can be stressful for people. And stress of coping with diabetes for those with diabetes or other chronic conditions can be very stressful, and there might also be some biochemical changes at the same time. So again, focusing on depressive symptoms alone might not be an appropriate prevention strategy. Lifestyle-related behaviors and cardiometabolic factors should be considered at the same time. And so in the area of diabetes, this idea of collaborative care models have been developed in the last years that focus on depressive symptoms, but at the diabetes, at the somatic condition at the same time. So there's a lot of evidence, not only for diabetes, but for other areas too, that on comorbidity and depression in chronic conditions. So focusing on depression, or someone who has a chronic condition and is depressed, sending this person somewhere else that he or she get treated for depression, and then coming back and other people will do the treatment for the somatic condition is not working, is not effective. So it improves depressive symptoms, but it does not improve the somatic condition. So the collaborative care idea and approach, I think it's very important, and the group around Caton started with these ideas, what they published in 2014 in the New England Journal of Medicine about this idea of collaborative care where depression and the underlying condition is treated and managed at the same time, and this seems to be a very important approach. So now I will, in the third part, link to the previous talk. So talk a little bit about cognitive functioning, how this is related, depression, metabolic risk factors, and cognitive functioning, and presenting some studies from some results from two community studies. I was working with colleagues in UK and in the Netherlands. So there was this, the date is missing, 2017, end of 2017, there was the Lancet Commission report on dementia. So what this report concluded is that there are modifiable risk factors for dementia, and that those modifiable risk factors might account for up to 35% of dementia cases worldwide. So this might be a little bit optimistic, and there was some discussion about this report in the Lancet, but it's still, there is the idea that now we have a lot of modifiable risk factors that might account, let's say, substantial portion of dementia cases. And what is also interesting is that those that are identified as modifiable risk factors based on systematic reviews and meta-analysis, that those modifiable risk factors are very similar to those for cancer and cardiovascular disease we know for a long time. So that's this idea, and here's this figure is adapted from the Lancet paper, so that modifiable risk factors might affect dementia in several ways. So there might be low brain cognitive reserve, might be a very important way, brain inflammation and increased brain damaging. And so what we see is depression and cardiometabolic conditions play an important role in this model of risk factors, and there might be an important interaction between those risk factors. So the analysis of those kinds of studies, associations for, and it's important that a lot of those risk factors are in midlife. So there was the idea we have to look at midlife risk factors in order to prevent dementia. But looking at those risk factors can be very challenging. So, for example, depression. We know there's some association between depression and dementia, as we've heard before. But now there's some evidence for depression, that we have at least different types of depression. So a late onset of depression, people who develop depression, report depressive symptoms after the age of 60, 65. So this might be a prodrome of dementia, while depression with the onset very early in young age might be a risk factor for dementia. So there might be opposite associations based on studies from like the Whitehall studies and some other studies. And some of the other risk factors are tricky too. So loneliness was reported as an important factor, but loneliness can be a part of, at least strongly associated with depression, can be a part of depression, or loneliness can also be for those people with who already developed cognitive problems, can be a result of the cognitive impairment. And hypertension. So we heard hypertension in mid-age is an important, high blood pressure is an important risk factor for dementia, but a drop in blood pressure in older people, so this is associated, can be an indicator of dementia. So blood pressure can have a very different meaning depending on the time we assess blood pressure in middle age or in old age. So it might be important to look at risk factors in midlife and see how those factors are associated with dementia. So we were interested in how do depression and cardiometabolic factors work together, and how is this associated with cognitive decline. So we did this working with the group in the Netherlands with the Rotterdam study, where we had a longitudinal community sample, and the idea was to see if depressive symptoms explain some of the association between cardiometabolic factors and cognitive decline. So then we tried to do this in the Rotterdam study and tried to replicate findings in the Whitehall 2 study in the UK. So very quickly about the Rotterdam study, it's one of the well-researched catchment area studies in the Netherlands and Rotterdam. So there are hundreds or thousands of papers now published from this cohort. So it started in 1999 with a catchment area study, a middle-class income area, where all participants living in this area were invited to participate, and there were expansions in 2002, 2004, and 2012, and there were follow-up assessments and later on. So people had to come to a research center and to get a comprehensive assessment of health and functioning, and later on cognitive functioning. So here we looked at cardiometabolic dysregulation based on factors I've presented before: blood pressure, glycemic control, cholesterol, triglycerides, obesity, and inflammation. And so that there was a comprehensive cognition assessment. Different tasks were conducted and assessments were conducted. So here we focused on 5 cognitive function measures, including the stroke test and verbal fluency tests and word recognition tests. So the Whitehall study, which was our replication, used as a replication study. I guess most of you have heard about it, have seen about it. Whitehall study started in 1985 in the UK. So it's not a representative sample. It started in London with office-based working people from 20 different departments. So that started with 10,000 people, and 10 follow-ups were conducted. So there was a clinical assessment every 4 years and interview in between every 2 years. So here we used wave 5 at the baseline, where age range was 45 to 69 years, so what we consider as midlife, and cardiometabolic factors, same as in the Rotterdam study, depression, CSD scale, and 4 cognitive measures here from the Whitehall study. So we used, again, structural equitation modeling to see if depression explains some of the association between cardiometabolic dysregulation and cognitive decline. So I will not go into the statistical details. I will try to present you the general idea picture. So the general idea model we used is, so there's something like cardiometabolic risk factors based on the different indicators. So it was assessed at time point 1. Then we have cognition, a cognitive G factor based on the 5 tests at time point 2. Cognition at time point 3, 4 years later, based on the same tests, so that we were able to model a cognitive decline, so change in cognitive functioning over time in this aging cohort. So then main interests, so what is the link between cardiometabolic risk factors and cognitive decline, and is some of this association explained by depression? So is there a pathway through depression which might explain some of the findings and controlling for some other factors? So when we compare the two studies, we see we have two very different studies, at least regarding to demographic characteristics. So mean age in the Rotterdam study was 65 compared to 55 in the Whitehall study, and in the Whitehall study was 75% were men, based on the office working sampling strategy. So important difference in age, and as expected, cardiometabolic risk factors were much lower in the Whitehall study compared to the Rotterdam study. So in the first step, when we looked at cognitive functioning, change in cognitive functioning, and association with cardiometabolic risk factors at the baseline, so we see those without cardiometabolic risk factors. So there is a cognitive decline, which is based on those tools, so which is an aging effect, which is expected and so not surprising. But people with 1 or 2 cardiometabolic risk factors had, so it's a change in G factors of 0.58, so a little bit more decrease, and those with 3 to 6 cardiometabolic risk factors. So there was a substantial difference, minus 0.65 to 0.53 for those without cardiometabolic factors. So again, confirming what we know from the literature, cardiometabolic factors and cognitive decline associated with each other over time. So when we looked at our model, so we see, again, what we described before now in a different way. So cardiometabolic risk factors increase the risk of cognitive decline based on our model here. But depression might explain some of the associations. So there was a cardiometabolic factors increase the risk of depression, which increase the risk of cognitive decline. So this might be one pathway, probably not the only one, but one among others, how we might explain association between cardiometabolic factors and cognitive decline. So in the study, we did a lot of sensitivity analysis. So we used diagnosed depression based on medical files, administrative data that's available, depression treatment, antidepressants, psychotherapy. We looked at recurrent depression, but we still found similar associations on the potential role of depression in the association between cardiometabolic factors and cognitive decline. And what was interesting, at least for us, that we were able to replicate finding in the Whitehall 2 study. So cardiometabolic factors predict cognitive decline, but some of the association explained by depression. So it was interesting because this was a 10-year younger, a mean age 10 years younger. So it was a much younger sample than the Rotterdam study, and we see this kind of association weaker, but still see an association in this younger cohort. So to summarize, both studies show there's a direct association between cardiometabolic factors and cognitive decline, and there might be an indirect association through depressive symptoms. That depression might explain some of the association we see between cardiometabolic factors and change in cognitive function or cognitive decline. Yeah, so this was a replication study, so where we were able to replicate findings. So a few words, interpretation, so what does this mean? So management of cardiometabolic risk factors, so this requires patient engagement, and depression might affect self-care behaviors, lifestyle behaviors. So there might be worsen of the management of the metabolic risk factors and cognitive decline through long-term exposure to metabolic risk factors. But it's only one pathway. There are other pathways that are probably involved, including dysregulation of the HPA axis and some other physiological and probably genetic pathways that are involved in this association. So people with metabolic dysregulation are at increased risk of cognitive decline, and depressive symptoms might partly mediate some of those associations. And again, for adequate prevention of cognitive decline, both cardiometabolic and mental health should play a key role. So I would like to finish with the slide. So we know depression is a very heterogeneous condition. And it's artificial condition. So we have, for depression, we have opposite symptoms. So people eating too much, eating not enough, sleeping too much, sleeping not enough. So we have really opposite symptoms in a very artificial construct. So it might be important to look more at specific depression subtypes like metabolic depression, which has been suggested in the literature. So there are different ways how people do this. Some people use data-driven approach and coming up with some ideas of atypical depression or specific depression subtypes based on data analysis approaches, or it might be other people use the combination of depression in combination with cardiometabolic factors, so metabolic depression. So I think it's important in this direction to focus on specific subgroups, which might be important for health outcomes like diabetes, but might also be important for other cardiovascular outcomes and for cognitions. So I hope I've shown you some example here, and I'm sorry about the slides. I've rechecked it before, and it seems to work well, but sorry about this, and yeah, thank you very much for listening.
Merci Denis. Donc on commence toujours par remercier le comité d'organisation de nous avoir invités pour parler, mais comme j'en fais partie, je trouve ça un peu bizarre. Donc je vais remercier surtout Denis d'avoir organisé cette journée, puis tous les autres membres du comité d'organisation, à part moi. Puis je vais vous faire la présentation en anglais, mais j'espère que je vais bien trouver mes mots. Je suis un peu fatiguée, j'avais ma demande des IRSC à soumettre hier, donc j'ai pas beaucoup dormi dans les dernières semaines. So today I will talk about the link between type 2 diabetes and depression. So we had a nice introduction before me. And so I'm not a specialist on depression. I'm more a specialist on type 2 diabetes. So I will talk more on the type 2, how people with diabetes develop depression. So diabetes, it's a very important disease worldwide. As you can see here, there is 382 million people affected by the disease worldwide, and probably 46% of the population is not diagnosed by the disease. And as you can see, there is a risk of increased of 55% increase of type 2 diabetes case in the next 20-25 years. So type 2 diabetes and pre-diabetes affect 11 million people in Canada. So it's affecting almost 1/3 of Canadians. And the most common type diabetes is type 2 diabetes, which represent 90% of people with diabetes. So you know that there is different type of diabetes, but type 2 diabetes is the most common one. So as you can see, it's the 7th cause of death worldwide, and it represents an economic cost of 10% of healthcare in a Western country. And so I will talk more today about type 2 diabetes, and type 2 diabetes is characterized by insulin resistance, and in my lab we are trying to understand what are the factors leading to insulin resistance, particularly in skeletal muscle, and how the muscle can communicate with other tissues, explaining why physical activity is beneficial for the treatment and the prevention of this disease. So during type 2 diabetes, there is insulin resistance and a progressive beta cell dysfunction. As you can see here, in the pre-diabetic state, there is a beta cell compensation, and then a beta cell dysfunction leading to beta cell failure, and it's where we call that type 2 diabetes when there is a beta cell failure. So what are the causes of beta cell failure in type 2 diabetic patients? So as you can see, there is physical inactivity, which is involved in this beta cell failure, as well as fuel sulfate. And there are different factors that can lead to beta cell failure. So genetic or acquired defects are involved in beta cell failure, but there is also different parameters, factors, as you can see here, such as lipotoxicity, oxidative stress, that are linked to the failure of beta cells. And all of this is linked to the low-grade inflammation. So it's linked to the development of a low-grade inflammation that we see with obesity and type 2 diabetes. So the causes of type 2 diabetes development are multiple. So there is genetic causes, but also age. You have more risk to develop diabetes with age. As we talked before, obesity, like being inactive is a high risk to develop type 2 diabetes. A poor diet with like a diet rich in saturated fat, for example, and also pollution. So it's something that we are looking in my lab to see how pollutants, environmental pollutants, can affect the development of insulin resistance and type 2 diabetes. So what are the complications? You probably know that with diabetes, there is a risk for your eyes, heart, kidneys, nerves, and teeth, and your brain, as we talked before. And today I will try to talk about the link between type 2 diabetes and the development of depression. So depression is a common comorbidity in patients with type 2 diabetes. As you can see here in this European study, they showed that there is like up to 30% people with type 2 diabetes that develop depression in their life. And this study showed that about 10 to 30 patients with type 2 diabetes are also diagnosed with depressive symptoms. And as a reminder, there is only 5% in the healthy general population that develop depression. So it's highly increased in people with type 2 diabetes. And so here it's a PubMed search that we did with the two keywords, type 2 diabetes and depression. And so you can see that before 2000, were very little number of studies we published with these two keywords, but as you can see, there is increased interest in this research area. So as the other researcher before presented, there is a bidirectional relationship between these two diseases. So diabetes can increase the risk to develop depression, but the opposite also is also true. So depression can increase the risk to develop type 2 diabetes, and the consequences of this comorbidity is that there is a decrease adherence to treatment, decreased regulation of glycemia, decreased life quality, and an increased complication of type 2 diabetes and an increased mortality. So how can we explain this comorbidity? So here it's the relation, like why people with depression can have a higher risk to develop type 2 diabetes. And this was was done by Tamid Ahmed, a master's student who is co-supervised by Denis and myself. So so he did a literature review to see which factors can explain the development of diabetes in people with depression. And as you can see here, there is inflammation can be involved. The HPA axis dysregulation can also decrease insulin sensitivity, leading to type 2 diabetes. Obesity and the metabolic syndrome is also involved in depression, leading to type 2 diabetes. And importantly, the medication for people with depression are linked to an increased risk to develop the metabolic syndrome, so to develop type 2 diabetes. And physical inactivity or sedentary behavior, as well as the increased calorie intake with depression can lead to type 2 diabetes. So concerning the relation in the other direction, why people with type 2 diabetes are at higher risk to develop depression. So it's probably due to psychosocial factors. When you're diagnosed with type 2 diabetes, you know that it's a chronic disease that you will probably have your entire life. So there is a development of depression due to the fact that you learn that you have this disease. And the diabetic complication can also lead to depressive symptoms. So we are interested in understanding why people with type 2 diabetes have a higher risk to develop depression. And as I just said, psychosocial factors can be involved. But we also think that other factors can be involved, and particularly biological disturbances, such as increased inflammation and oxidative stress that are both involved in the development of type 2 diabetes and depression. And as we talked before, behavioral factors may be also involved, such as decreased physical activity or increased sedentary behavior, increased poor diet habits, and lack of sleep. And we know that these two factors may be involved in the development of diabetes and depression, but we don't know if it's linking the two diseases. So we have an ongoing study which tests this hypothesis. So if biological disturbances such as inflammation, oxidative stress can be involved in the development of depression in people with type 2 diabetes. So we are looking at psychological factors and also behavioral factors. So the general objective of our study is to identify psychosocial factors, biological disturbances, and behavioral factors associated with the presence of depression in people with type 2 diabetes. So it's a cross-sectional study. We are comparing 4 groups of patients. So in the first group, it's the control group. They are healthy. They have no family history of type 2 diabetes. In the depression group, they don't have type 2 diabetes and no family history of type 2 diabetes. In the type 2 diabetic group, they don't have depression and they have type 2 diabetes. And in the comorbidity group, so the patients, they have type 2 diabetes and depression, and they don't have history of depression pre-diabetes. So we decided to recruit only people with obesity, because we know that type 2 diabetes is linked to obesity. And we also recruited people with HbA1c lower than 9% to avoid diabetes with complications. And we excluded some medications, for example, medication affecting metabolism and anti-inflammatory drug, because we are looking at inflammation in that study, and insulin treatment for type 2 diabetic patients. So there are only patients treated with metformin or other drugs, but not insulin. So it's a very simple protocol. So there is 2 visits. Between the 2 visits, the participants wear an accelerometer to measure their habitual physical activity, and they do a 3-day food journal to measure their food diet habits. And at the first visit, we measure their HB1AC, and they have different psychosocial questionnaires. We do anthropometric measurement and a 24-hour dietary recall. And at the second visit, which is 7 days later, they have a fasting blood sample, and to measure glucose, insulin, free fatty acid, triglyceride, oxidative stress markers, and inflammation markers, and we do a body composition test. So here is the preliminary data of our study. So it's really preliminary. We have recruited some participants in each group, but as you can see, I have highlighted in orange here that the groups are not even in terms of the number of participants in each sex. So interestingly, we have more women that participated in the two groups with depression. So I would like to talk about this with people people that know more depression than me. Why we have more female with depression participating? Is it because there is more depression in female than in male, or it's because male with depression doesn't want to participate to research or to say that they are depressed? So this can affect our result because, as you can see, we have a higher body fat mass in the depression group. So it's not significant, but the numbers are higher. And we have also a lower fat-free mass in the depression groups. So concerning the Beck depression questionnaire, as expected, the two depression groups have a higher score in that questionnaire compared to the diabetic group without depression or to the control group. So in that questionnaire, there is some question about symptom distress. And so here it's an example of question. I tired quickly, almost always, frequently, sometimes, rarely. And as you can see, again, it's significantly higher in people with depression. And it's not different between the comorbidity group and the depression group. Interestingly, for that part of the questionnaire, the interpersonal relationships, it was significantly higher in the comorbidity group only. So one example of question is, I get along well with others. So apparently there is maybe something with interpersonal relationships when you have the comorbidity, type 2 diabetes, depression compared to depression only. So concerning the social support, again, the scores were lower in the two depression groups, but for this parameter appreciation, it was lower only in the comorbidity group. So we also looked at experiences in couple relationships, and interestingly, anxiety and avoidance, so measured in the context of couple relationships, were significantly higher in the comorbidity group. So concerning the regulation of glycemia, so as you know, HB1AC is a marker of the glycemic control in the past 3 months. So it was higher in the two type 2 diabetic groups without differences between the diabetes group and the comorbidity group. So we also had a questionnaire about the attitude related to type 2 diabetes, and interestingly, there is some significant data showing that people in the comorbidity group have higher conviction on illness and need for special training, as well as they have lower patient's adherence. So we measured their habitual physical activity levels with accelerometers for a week, And at one point in the study, we had a significant decrease in physical activity in the comorbidity group, but it's not any more significant. But there is a trend for lower physical activity in the comorbidity group. And interestingly, the score of depression are correlated with the level of physical activity of the participants. So it's pulling the comorbidity group with the depression group. So concerning the quality of sleep, so the Epworth sleepiness scale didn't show any significant difference in the quality of sleep between our four groups. And so we are also looking at the role of diet in this comorbidity. And Alexandra Bodnauk, who is here today, will present you a poster on that. So I invite you to see a poster later today. And for the markers of inflammation, so it's very, very preliminary. As you can see, we have a very low number of subjects per group here. And unfortunately, when we measure the different cytokines, the method was not sensitive enough to detect the cytokines. So we were able to have data only on interleukin 8 and TNF-alpha. And we don't have any significant difference, probably due to the fact that we don't have a high N in each group. But as you can see, there is a tendency to have higher inflammation in the two groups with type 2 diabetes compared to the depression group or the control group. So this study is limited by the fact that it's a cross-sectional study, so we would have liked to do a longitudinal study, but we have a very hard time to recruit our participants. So our idea was to take people with diabetes in the first 6 months after their diagnosis of diabetes and to follow them over time to see if those who develop depression have different markers and the different factors that we are measuring over time than the people who doesn't develop depression. But for now, we are doing this cross-sectional study because it's much easier. And as I said at the beginning of my talk, we have more women in the group with depression, so that can explain some of the results we have in that study. And we have still a small number of subjects per group. So to conclude here, we showed that some psychological factors may be involved in the comorbidity type 2 diabetes depression. So interpersonal relationships, appreciation-related social support experiences in couple relationships are more altered with the comorbidity. So there is a trend for lower physical activity in the comorbidity group, and there is a nice relationship between the level of depression and physical activity levels. So is it a cause or a consequence? And we talked about it before. So is it because people are depressed that they don't exercise, or it's because they don't exercise that they are depressed? But we know, interestingly, we know that if we do a physical activity intervention with people with depression, they will decrease their depressive symptoms. So even if it's maybe not like the cause of the development of depression, like treating these people with a physical activity intervention is efficient. So I would like to acknowledge the people who are involved in that project. So my collaborators, so it's a multidisciplinary team, as you can see. We have people in nutrition, so it's Isabelle Giroux, Jean Grenier and Paul Greenman are two psychologists. Pascal Imbeau is a specialist in physical activity and sleep behavior. And Eva Guerra was the biostatistician on that study. And here are the students who were involved in the study. So Lucia Sheade, Victoire, Tamid, Abdi Jafar, and Keridine, who is a volunteer who helped with the recruitment. Thank you.
So I'm really pleased to be here with you today, especially because this is my birthday, and what better to do with a birthday than to come to Ottawa? Huh? Wait. So when I got invited by Dr. Prudhomme, I said, well, when you mentioned March 7th, I said, well, that sounds like a special day for me. So, and in fact, it's a way for me also to celebrate something that has really been a passion of myself, trying to understand the connection between depression, heart diseases. And this is something that is personal in some ways. Now, obviously, when you become a psychiatrist, you have to reflect why you go to psychiatry. I'm not sure about cardiologists do that, but psychiatry probably are mandated to reflect on why. And my grandfather on my father's side had bipolar disorder and died at 60 years old of a heart attack. He was a smoker, obviously. He was obese, and he died of a heart attack. And I was born in 61, so I didn't remember him. I missed him. And I have another grandfather. I have two grandfathers. The other one died at 68, also of heart attack, and he was having alcohol problem. And these things are related in many ways. We know stories from many people, and maybe that explains some of the connection in my career. So we'd like to start with, I have no conflict of interest, to thank Nancy Fraser-Smith that has been, we have been together in this journey for many years. And she has been obviously very similar. We had really a great working relationship, me a physician, her a PhD, working together, trying to resolve the research question and trying to implement our research agenda. And we also did that with many other collaborators. Diana is here. We had a great study together that will report some of the data. And many cardiologists, Peter, you know many of them on the slide. I was fortunate to be to do my research at Montreal Heart Institute for most of the years. It was a great place. The cardiologists there were quite supportive of trying to help our research agenda on that, and so I really want to thank them along the way. This is the first paper that put us and myself on the map. I have been on practicing when that came out for about 4 years. We have been doing research on starting to get cohort studies, and this is the paper that has been highly cited, was published in JAMA, where we showed that patients who were depressed at the time of a myocardial infarction were at 4 times the risk of the non-depressed who die over 6 months. That's after controlling for other predictors of mortality in the data set, including ventricular function and previous MI. So that was, and basically it attracted a lot of attention, obviously, and more grants, and we follow up with other studies on that issue. And so it's really important for me that to say now, and then we are going to repeat it later, is that those who are at risk are the depressed patients. It's not necessarily because they are depressed, or it's not necessarily depression itself that make them at risk. And I'll try to explain some of the distinction. And we've been in some ways looking at that. You know, there's so much comorbidity between depression and other risk factors that it's difficult whether or not it's depression itself or other factor that correlates with depression among depressed patients that put them at risk. This is interesting because this is a long-term follow-up of different level of depressive symptoms over 5 years. And then you see those relationship between depressive symptoms at baseline, after myocardial infarction, and mortality over 5 years. And that's, again, adjusting for other risk factors. It's very interesting that one measure, simple measure, in hospital can be so predictive over so long after an event like myocardial infarction. So there's something that comes with depression or being depressed that is chronic, obviously. And then this is like a meta-analysis that is, I don't want to repeat all the studies, but show that among patients who have CHD, depression predicts outcome after adjusting for all confounders, and increase the risk about by 60%. So it's less than the 4-time increase that we found, because of different samples that was collected, the different ways we define depression. So, but it's a robust predictor. And so that's for depression. Obviously, the depression comes sometimes with anxiety. There's other psychosocial risk that has been documented, including anxiety. And here, that's one of the findings that we found is that patients who have a diagnosis of of anxiety or have symptom of anxiety or increased risk of 2 years of cardiac events. And then you can see that it was mainly in men, and it's either or. So it's either depression or anxiety. And again, that speaks to the fact that when you look at the pathophysiology of depression and anxiety, they share a lot of common background in terms of exposure, environmental exposure in terms of genetic risk. And that's probably also related to that. So some key findings in terms of the relationship we just reported, that it's not limited to major depression. So the back slide show you that, and I want to just come back to this. It's even at between 5 and 9. So 5 and 9, it's when you get up in the morning, you're not happy, but that's not depression. And so even a low level of depressive symptoms one time in hospital predicts something. So I guess there's some people who are happy about MI, I don't know why, but not disturbed by it and at all. And what is that? I'm not sure what it is, but it's even a normal dysphoric experience after an MI increase the risk. Obviously, more severe depression, it's put them at higher risk. The dose-dependent relationship, it's dependent of other prognostic factors, and it's not only depression. Anxiety is probably play a role in the relationship between emotions and heart disease. And here, it's depression as a risk factor for development of heart disease. And here again, when you look at the summary of all studies that look at this question, it double the risk. So, and that's even 20 years after the first manifestation of heart disease. And usually depression starts early on. It's like around 20s, 30s, at the time where if there's heart disease, it's really subclinical. So that's probably say something about the duration of the relationship between depression and heart disease. So is it cause-effect of coincidence? And I think that has been around here in other talks. In terms of behavioral factors, we know that depressed patients are less likely to exercise. That has been documented. They're more likely to smoke. And they are less likely to be compliant to their medication. So all things that probably have an effect on the outcome. And I've been around, and I will insist more on inflammation because that's the savor of the time, about the impact of inflammation on and relation between depression, inflammation, and heart disease. In terms of medical adherence, of medication adherence, this is just an example of that. This is the people taking the aspirin, which is an important medication after MI, as they're with depression. And you can see those who are more severely depressed are less likely to be taking the aspirin on a daily basis. And that was done by having a recording device on the cap of the bottle over time. That has been done at Columbia with a group of people I've been collaborating with. And it does show that that's a correlation, obviously. What they look is over time. This is a cross-leg analysis looking at what's the impact of depression over time on medication adherence. And when you look at for example, there's correlation between depression at 2 times, obviously. Those who are depressed are more likely to stay depressed. And that's the correlation that between time 1 and time 2 is 0.72. That's high. But those who are become depressed or are depressed at time 2 are more likely to not adhere to their medication at time 3. So becoming depressed or change or in severity of depression increase the likelihood of not taking your aspirin, which is obviously could have an impact on prognosis. Now I'm going to change to, and I don't want to review all the literature on exercise for time constraint. I will go on mechanism now. So here it's a panel that showed the possible relationship between how inflammation can, in fact, lead to depression. And so this, we know and has been around that atherosclerosis and MI are inflammatory, in part, inflammatory diseases. So there's a lot of cytokines circulating in the body in relation with atherosclerosis. And these cytokines cross the blood-brain barrier in two ways, directly by the blood-brain barriers, and also cytokines through the afferent vagal nerves. So the peripheral cytokines influence the brain, and there's good reason for that. Peripheral inflammation signals something in your body, and your brain, as an animal, needs to take account of that for adaptation. So cytokines in the brain, peripheral, influence the brain. And so that activates the HPA axis, the stress response. It reduces serotonin, increase leukocytosis firing, and induce apoptosis in the brain. So there's a lot of cascade effect of cytokines in the brain. And in animal research, there's this syndrome or called sickness behavior in rats. If you inject cytokines in rat brains, you induced a behavior which mimic depression. Hedonic, they don't eat, they sleep a lot, they have impaired cognitive capacities, they have difficulty to find their ways in maze. So there's direct effect of cytokine on behavior that mimics depression. So, and it has been meta-analysis in terms of correlation between depression and CRP. For example, CRP is a not cytokine, but a fluttering marker that is secreted when there's a signal of inflammation. But the effect size is not huge, so 0.15 effect size when you look at all the studies. When you look at a clinical sample of depression, that's the bottom of the table, the correlation is 0.18. So there's some correlation between depression and CRP, but not a strong relationship. And here it's the relationship between IL-6 and depression. Again, some relationship, but you have to realize that this is a correlation between blood sample from your vein to depressive symptoms. And you can imagine that it shouldn't be that direct. Now, how cytokines in periphery relate to cytokines in the brain, no, it's not clear. Now, we need to be cognizant of the fact that there's a distance between the brain and what's circulating in your blood. And not everybody is probably sensitive to cytokines in terms of behavior. Not everybody, when they have a bad cold, oversleep and are really tired and non-functional. So some people are probably more sensitive to the effect of cytokines than others. And so I have colleagues in Montreal that look at that model among rats. So they created an MI in rats and tried to look at the brain effect of that MI. And so they found 3 days after the MI that there was apoptosis in some brain region induced by the MI. And the apoptosis was blocked by some drugs. And among the drugs that blocked the effect of cytokines on apoptosis in the brain is sertraline. At that time, they tested sertraline. They tested citalopram, they tested omega-3, they tested anti-cytokines, and all were able to block the effect of apoptosis in the brain. And that's very interesting. So that's acutely, obviously. You need to get the drugs during the MI, which don't happen in clinical setting to prevent that. But there's also an inverse relationship. So external stress, and you can test that in rats, if you induce stress, you induce cytokines in the brain. And these cytokines in the brain have so could influence the heart and the response, the physiological response. And that also makes sense. Now, when you anticipate a threat, you need to gear up your body to respond to that threat. And that one possible threat, external threat, is infection. So that makes sense in terms of development of species, that when there's a stress, it's non-specific, and you have to basically be prepared to it. And so just two slides that I found really fascinating. That was done by Greg Miller, a health psychologist that was in Vancouver, now moved back to, I think is in Chicago. And what you show here is that the low early life socioeconomic status. These are among normals. You take those who were, 15 minutes? Okay. You take those who were early on stress and by the economic status and their activity to a stimulant on the blood cells. And those who were having low economic status had an increase in cytokines as an adult. Without so it's basically, it's programmed in your childhood how you react to stimulant. And among the stimulant, if you have to react to an infection, you're more likely to react a lot. And here it's for those who are psychologists who believe that childhood matters in terms of development. But in mothers play a key role in your brain development. Here, so Greg Miller and his wife with Edith Chen work on that question, and they found that those who recollect their past as a mother was warmth buffer the effect of stress in adulthood. So it's really interesting how you can test really, construct that is important. So one question is whether or not a chronic stress, how we regulate our defense mechanisms against aggression that is programmed in childhood. And in some ways, our depression and coronary artery disease, both manifestation, different phenotypes of upregulated stress response. Can we prevent the impact of stress on outcome? This is the solution of death. We've been hoping to be cardiologists, and we are not cardiologists. We don't save lives that easily. So we did a multi-center trial, and we tried to reduce the stress among men and women and over 1 year and tried to find out whether or not it reduced cardiac events, and it did not. It's really hard to reduce cardiac events. And here you see the two upper line are men, identical outcome. Over 1 year for the women, those who were randomized in the control condition did a bit better than those randomized to the psychosocial intervention. If anything, the psychosocial intervention didn't help the women. And so I can speak a lot about that if you're interested in the lunch. Women are different than men in many ways, but in terms of reacting to psychosocial intervention, it seems to be the case when they are elderly. And that has been also a question of the Enrich trial, which they tested CBT as the psychological intervention among depression, and no effect at all. And so I'm going to skip this one. They have another trial trying to do a comprehensive package intervention, including medication and psychosocial, which is Kodiak and Cobes. Some effect on depression. Here is the effect on depressive symptoms, but little effect to be found in the long run on cardiac outcomes. So to just summarize up to now, it's there's a link. So far, we've tried to reduce the depressive symptoms with some efficacy, with some intervention, but not able to translate that in the reduction in cardiac outcomes. So we did, randomized trials, 2x2 factor design, trying to test efficacy of antidepressant in psychotherapy for depression in stable coronary disease patient. And this is the effect on depressive symptoms over time, over 12 weeks. And citalopram was better than placebo in reducing depressive symptoms. And the effect size is similar to the effect size found in antidepressant trial. You have to realize that those are not that familiar with antidepressant trial. If antidepressants are efficacious but not hugely efficacious in depression, placebo is also quite efficacious in depression. And so other people try to replicate similar studies, and this is one done among CHF patients, and sertraline was not superior to placebo for major depression. So it's not easy to treat patients with comorbid medical condition when they are depressed. It's harder, and sometimes antidepressant works, and this time antidepressant did not work. This is the effect of the other arm of the study. So it was a 2x2 factorial design. So we tested citalopram in comparison to placebo, and we tested interpersonal psychotherapy in comparison to clinical management. Clinical management is spending 25 minutes with the patient doing a clinical visit, and IPT is like a structured psychotherapy. The people who were doing psychotherapy were also doing the clinical management. So it was really like trying to have a placebo embedded in our trial. And here you see that the patients randomized to clinical management did a bit better than that was marginal than people randomized to IPT. So psychotherapy, like medication, is not the cure for everything, and so we need to test different intervention, and that showed that IPT in that population didn't have a huge effect or was not that great. And this is an example that maybe not be that bad. Here it's Ken Friedland, that is a health psychologist, a big believer in CBT. Compare CBT, supportive stress management, which for him was like placebo, something light, and usual care. And in many ways, CBT was similar to stress management for a patient after bypass surgery. But there's new treatment, well, not new treatment. We overemphasize psychotherapy and antidepressant for treatment of depression. And for patients with heart disease, maybe we need to look at something that is also have health benefits. And here's a meta-analysis of the efficacy of exercise for depression. And the effect size is about similar to the effect size of psychotherapy and medication for depression, about 0.4. So exercise is underutilized treatment for depression. And what is good about exercise that it does reduce the inflammatory response. So here you have the effect of physical activity on CRP. It shows that there's some effect of exercise on reducing inflammation by many mechanisms, but that's a healthy effect of exercise. So if I come back to is depression a risk factor or risk marker for coronary disease? I would like you to try to see the difference between the two. If depression is a risk factor, that means depression itself as a state increases the risk of cardiac events, then obviously if we have to design something, we'd have to design something that reduces depressive symptoms, that is a cure of depression. And we have to select treatment that is the best blend of treatment that reduces depressive symptoms. But if it's the depressed patient that are at risk, I mean, it's the patient himself that you want to focus on, that it's a risk marker, and then you have to focus on maybe a better blend of cardiovascular treatment and make sure that patient adhere to the cardiovascular treatment. And it means, so adhere to medication adherence, adhere to take their statins, their aspirin, exercise, and maybe, by the way, they're going to be less depressed now if they do all that. And so treating the patient as a global patient and focus on the cardiovascular treatment, because this treatment has been shown to be efficacious to reduce cardiac events. So why we don't, if you want to reduce mortality, do that first. And that, I've been a defender of that approach. We had some talks, how we should plan the next big trial. That was like 5-6 years ago. Now we're trying to push for a big trial to NHLBI, like 10,000, 12,000 patients, and for me, I was quite opposed to focus on depression, focus on giving antidepressant, because, and also there's a literature where the antidepressant may have cardiovascular risk anyway, so it's not necessarily all safe. And my intuitions were saying that, well, if such a trial has to go or have been funded, it has to be tailored to most of the needs of cardiovascular patient. And most of them who are depressed don't necessarily see themselves as depressed, or don't see themselves as having something that has to be addressed by psychologists or psychiatrists. In fact, there's some resistance to that. So the center of that kind of attention should be cardiologist in some ways, or the internist, or in a different setting. To summarize, depression is physical disease, and I put physical disease in quote unquote because depression in some ways is a physical disease because it's a disease of the brain. They probably share multiple pathophysiological mechanisms, and depression by itself is not one disease. It's by convention a syndrome, but it's probably many different types of depression. There's limitation of our phenotypes in psychiatry. As I said, there's no overlap between depression and anxiety, overlap between depression and addiction, overlap between, and so that's a limitation. And they share many determinants of health. So there's no evidence that any intervention targeting depressive symptoms improve cardiac outcomes. There's some documented efficacy of citalopram and maybe sertraline in the cohort for depression. In terms of non-pharmacological approaches, obviously there's a promise of exercise. The problem is that it's not easy to get anyone to exercise, not mention depressed patient. So it works, but the question is how can we make it work more or more frequently and have a huge impact? That means be outreach to a lot of people. And how can we do that also with cardiac adherence to medication? We know that in the best case scenario, there's about 30% of the patients who stop taking their antidepressant, their statins, over time don't take it on a regular basis. So there's something there, and probably something there. People don't want to be reminded that they are sick for 25 years. At some point, this medication, they lose it become more distant to have other events. Obviously, we prevent, but if we go from 5% mortality over 5 years to 3% mortality, for many it becomes really abstract. So we need, and we have to start earlier. Now, it has been said, if depression starts at 20 years old, then we know that inflammation and exposure to stress in the childhood and play a role, or may play a role, and that could become heart disease later on. We have to start not when people have heart disease at 50 years old. We have to try to do something on a public basis much earlier. And that's a little evidence of psychological intervention improved cardiac prognosis. Thank you very much for your attention.
Thank you. So today I will present some preliminary results from a study that is being conducted here at the Montfort Knowledge Institute by Céline Aguerre and colleagues. And the study, it's looking at factors of psychosocial, biological, and behavioral factors that could explain the type 2 diabetes and depression comorbidity. And more specifically, for my poster, I looked at differences in dietary fat intakes between healthy participants, participants with depression, participants with type 2 diabetes, and participants who had both depression and type 2 diabetes. The comparison is supported by some studies that show an association between the type of fats that are consumed and the risk of developing both type 2 diabetes and depression, as well as by the association between the type of fats and inflammatory markers. So when we looked at, we assessed differences in this sample, we found no difference in total fat, monounsaturated, polyunsaturated, and saturated fat, which might be explained by the rather small sample size, as well as by differences in the number of participants that were in each of the groups. Thank you.
So I'm not going to repeat a lot of what Dr. Heather Tulloch just said, so I'm going to be only 1 minute. So before we embarked on a larger randomized controlled trial of the Healing Hearts Together program, we conducted a pilot project, and this was with 33 couples, and we gave them a questionnaire to see if they were satisfied with the program, and what Heather said, they were very satisfied. But we were really interested in their reasons for satisfaction. So we conducted a qualitative study. So participants responded to 7 open-ended questions, and we got a lot of feedback, almost 300 comments, and we grouped these comments into categories. And so overall, participants felt that there were really positive changes to the relationship, so it improved communication, openness, and empathy. But really interestingly, they felt that the program helped to demystify relationship processes. So they learned how to recognize patterns in their relationship when things weren't going all right. They also learned that these processes are normal, and so that really gave them a lot of comfort to talk to other participants who were feeling the same thing. They also believed that the sessions provided a really safe learning environment, so they're able to talk about these things that can be potentially quite distressing amongst other people, and felt very comfortable, so that was very promising. So overall, there's a really strong participant satisfaction, which provided a lot more justification for us moving forward with the randomized controlled trial. So if you want to learn a little bit more about Healing Hearts Together or our participant satisfaction survey, I will be over there. Thank you.
Distance does make the heart grow weaker. I just have to say, I'm tickled pink, absolutely giddy, that in every single presentation that has been done today, somebody has talked about the importance of relationships and social connection. Dr. Hakim talked about loneliness as being a risk factor for stroke, about how isolation and loneliness in young people and blood pressure is through the roof. I don't think that's a coincidence. Dr. L'Espérance said on more than one occasion, these people need to be connected to somebody. So we're seeing that, improving people's relationships isn't just about quality of life, it's about also improving their health. And this study, it's not a clinical study, this is more of a fundamental research investigation, where we looked at people, heart patients. So we had 128 patients who had suffered a myocardial infarction within the past year, who were recruited here at the Montfort Hospital and also at the Ospedale San Giovanni in Rome, Italy, and control participants who were all recruited here. So these are participants who were in good health. And we found, unsurprisingly to me, that people who tended to exhibit what we call an avoidant attachment style, people who tend to say things like, relationships aren't that important to me, I don't really need them very much. In my couple relationship, I don't tend to open up to my partner or to rely on him or her at all. Well, those people were significantly more likely to have had a myocardial infarction in the year following the disease than the control condition. So we're finding that not only does distance seem to be related to the onset of heart disease, emotional distance in a relationship. We're not talking about physical distance here, very important distinction. Emotional distance seems to be related to the onset of heart disease. And of course, also not surprisingly, people who had this type of attachment to their partners tended to exhibit less relationship satisfaction. So that's the low kind of relationship quality that Heather talked about as being a risk factor. So if that's interesting to you, come and see me.
Donc, bonjour à tous. Ça me fait plaisir de vous parler très brièvement du programme Cœur et l'Esprit. Alors, qui s'intéresse au traitement de l'anxiété, de la dépression et du stress post-traumatique chez les hommes ayant vécu un événement cardiaque. Alors, the Mind the Heart study is funded by the Movember Foundation, hence the emphasis on men's health per se. It's a 3-year study conducted in 3 provinces, Ontario, Quebec, and New Brunswick. So we started off with a qualitative study of needs and acceptability with men, managers, and health professionals, and implemented a program to help men better manage symptoms of anxiety, depression, and post-traumatic stress post-cardiac event. So our program involves a stepped care approach tailored to the masculine gender. And the intensity of psychological distress as well. So it involves a first step, which involves psychoeducation tailored to the masculine gender. A second step, which involves a group intervention, a portion of which the significant other is invited to the sessions. And we have some interventions that Heather Tulloch alluded to just prior to this. And if that's not enough, we also have a third step, which involves individual therapy or couples therapy based on patient preferences. So in this context, we develop tools with the content adapted to the masculine gender, and tools for patients as well as health professionals for training purposes. We have psychoeducational material. We also have a treatment manual as well for group and individual therapy, as well as for couples therapy, as well as an online training course for health professionals wishing to provide that type of service. So we haven't analyzed all of the data yet. We're still finishing the study. But as a next step, we plan to work with managers and health and decision makers to implement or integrate this type of intervention as part of rehab programs in participating sites. So there you go. We will be right there. Thank you.
So depression is associated with abnormalities in the autonomic modulation of cardiac activity, which could potentially underlie the increased risk of cardiovascular disease amongst this population. And this also results in distinct patterns of heart rate and heart rate variability during sleep. And so in this study, we aim to validate a diagnostic algorithm that was developed by a medical technology company that uses patterns of heart rate changes during sleep to distinguish between individuals with and without depression. So this was a machine learning algorithm that was trained on the EKG data of over 1,200 individuals, and then tested in a distinct sample of 87 individuals with depression and 87 healthy controls. And we compared the classifications by the algorithm with medical record diagnoses, and we found that the algorithm had an accuracy of 79.9%, with a sensitivity of 83% and a specificity of 77%. We also tested the algorithm's sensitivity across various subgroups of depression based on factors such as depression severity, the presence of cardiovascular disease, and cardiovascular medication use. And we found that the algorithm remained highly sensitive. And so overall, this suggests that sleep-derived heart rate patterns are valid physiological biomarkers of depression and could potentially be used as an adjunct diagnostic tool. Thank you.
Okay, well, merci Denis. Et merci d'avoir organisé cette conférence. C'est vraiment excellent. So good afternoon, everyone. And so my presentation is on psychosocial interventions for anxiety and depression in people with Parkinson's disease. Okay, so for those of you who are not familiar with this disorder, it's a progressive neurodegenerative condition that's characterized by loss or dysfunction of dopamine neurons in the substantia nigra of the brain. And the key symptoms of this disorder include tremor at rest, rigidity, slowness of movement, and postural instability. It affects about 1% to 2% of people 60 years and over in men, and there's a higher prevalence in men than in women. The cause of the disorder is unknown, and there are no cures for the disorder. And although there are a number of effective treatments that can manage the symptoms of Parkinson's disease, they don't stop the progression of the illness. So non-motor symptoms are very common in people with Parkinson's disease, including high rates of psychiatric symptoms. This slide shows some of the common symptoms that are associated, non-motor symptoms that are associated with the disease. Some of them are due to the direct pathophysiological effects of depression, but some of them, like psychosis and impulse control symptoms, can actually be due to the direct effect of the Parkinson's medication. So depression is the most common non-motor symptom reported in people with Parkinson's disease. It's estimated that about 40% of people experience clinically significant depressive symptoms. Some studies suggest that this rate might be as high as 80%, and about 20% meet diagnostic criteria for a depressive disorder. Often, depression is comorbid with anxiety disorders and with anxiety symptoms, which is what we also see in depressed patients with no medical conditions. Depression is more prevalent in Parkinson's disease than it is in non-Parkinson's populations and other chronic illnesses, and twice as common in Parkinson's disease than in conditions with equal disability. Depression often precedes the diagnosis of Parkinson's disease, and some people believe that it may be an early symptom of the disorder or perhaps a risk factor for developing Parkinson's disease. The etiology of depression and Parkinson's disease is unclear. It's probably very complex and likely due to both biological factors such as deregulation of catecholamines and serotonin, and also psychosocial factors. So with respect to anxiety, about 40% of patients experience substantial levels of anxiety, with about 25 to 49% meeting a diagnostic criteria for an anxiety disorder. The most common anxiety disorders reported in people with Parkinson's disease are panic disorder with agoraphobia. So panic disorder is characterized by recurring panic attacks and fear of having future attacks and avoidance of situations where the feared panic attacks might occur. Generalized anxiety disorder, which is characterized by excessive and uncontrollable worry and anxiety that's accompanied by physiological arousal. And social anxiety disorder, which is an intense fear of being negatively evaluated by other people and avoiding situations where a negative evaluation might occur. Anxiety and panic attacks are common features of the wearing off of levodopa medication, so it's called wearing off anxiety, but this is not a universal experience, so not all patients report this. Some, but not all, studies also report that frequency of freezing is associated with anxiety. Similar to depression, the cause of anxiety in Parkinson's disease is unclear, and again, likely due to both biological and psychosocial factors. Now, a number of psychosocial factors have been linked with the onset or exacerbation of anxiety and depression in Parkinson's disease. Actually, many of these have already been discussed earlier this morning as they relate to some of the other medical conditions and risk for depression. But just quickly, some of the factors include difficulty adjusting to the losses and demands associated with this illness. Parkinson's disease is associated with a lot of losses, giving up of valued activities, roles, and these losses continue as the disease progresses. And also, the demands associated with this illness are quite remarkable, and for many patients, their life actually revolves around this illness, and this certainly can result in a lot of anxiety and depression. use of inadequate coping strategies, perceived uncertainty of illness. Of course, people are always worried about when they're going to get worse, the progression of their illness, and this can be a real preoccupation for a lot of people with Parkinson's disease that can result in a lot of anxiety and depression. And if people are intolerant of uncertainty, their level of anxiety will be much higher. Many people are hypervigilant to the signs of decline in function. Many people have feelings of shame associated with Parkinson's disease to the point where they won't even tell a family member that they have been diagnosed with this condition. And of course, feelings of shame result in people avoiding social situations that can result in them developing depression. A negative cognitive style and dysfunctional attitudes contribute. We talked a lot this morning about the importance of interpersonal supports and social isolation being linked with depression, and of course this is also the case in Parkinson's disease. So the presence of anxiety and depression comorbidity is associated with a much poorer outcome than just having Parkinson's disease alone. Anxiety and depression have been reported to exacerbate motor symptoms and cognitive decline. If you work with people with Parkinson's disease and they come into your office and they're upset or anxious about something, you can really see an increase in their motor symptoms. So there's a real profound effect of anxiety symptoms on motor symptoms. It can result in decrements in self-care, including engaging in health-promoting behaviors that are important for Parkinson's disease, like exercising, also with high levels of dependency, greater caregiver distress, and increased mortality. And many studies consistently report that anxiety and depression, especially depression, is a much more important predictor of poor quality of life in people with Parkinson's disease than the actual disease itself and its treatment. So unfortunately, despite the negative consequences of anxiety and depression on Parkinson's disease, most patients don't receive adequate treatment. This may be due to the fact that anxiety and depression are under-recognized and under-diagnosed because of the overlap between symptoms of anxiety and depression and motor symptoms. And also mental health care utilization is very low in people with Parkinson's disease. And this study by Trung, if I'm pronouncing his name correctly, found that only 8% of people with Parkinson's disease access mental health services. So this is a real concern. And this could be due to many factors, such as perception by the patient and their families that perhaps depression and anxiety are normal reactions to the disease, stigma associated with having mental health problems, and also barriers to accessing evidence-based treatments, especially psychological therapies that are a little bit more difficult to access than pharmacotherapy. So currently there are no treatment guidelines for the treatment of anxiety and depression and Parkinson's disease, and so most patients are not being treated optimally. Medication is often the first choice of treatment because of an emphasis on biological factors in the etiology of depression and anxiety in people with Parkinson's disease. And while many antidepressants are very effective in treating symptoms of anxiety and depression, they're not without limitations. So many patients are unable to tolerate side effects, which can affect compliance with treatment or the ability for the physician to titrate the dose to an optimal dose for these symptoms. There's always a concern of potential interactions with Parkinson's medications and other medications that these patients may be taking if they have other comorbid medical conditions. Also, many patients prefer a non-pharmacological approach. This is important. Treatment preference is important because it predicts treatment response and also compliance with treatment. So it's very important that we consider what do patients want when for the treatment of their anxiety and depression. Also, there's a greater risk of having a poor response to medication and for relapsing after medication is discontinued if the psychosocial issues that are relevant or contribute to anxiety and depression in these patients is not adequately dealt with. So there are many psychotherapies, but very few of them have been supported by rigorous research. I think there are about 250 or 300 different types of psychotherapy, so it's a lot out there. And also very few of them have been specifically developed for the treatment of anxiety and depression. Nevertheless, when we look at first-line psychological therapies for anxiety and depression, the research shows that they are just as they work just as well as medication for people with mild to moderate levels of anxiety and depression. So this is nice because it provides patients with a treatment option that might be more preferred. So this slide shows some of the first-line psychological treatments for anxiety and depression in non-medically ill patients, and these are therapies that have been endorsed by different treatment guidelines, including the Canadian Network for Mood and Anxiety Treatment. So for anxiety disorders, CBT, I think, is really the best researched intervention, and an intervention that has shown to have very strong, moderate to strong effects for all of the different anxiety disorders. And cognitive behavior therapy includes a number of treatment components, and the aim is really to modify maladaptive thinking and beliefs that fuel anxiety, and as well maladaptive behaviors that maintain anxiety, like avoidance behavior. For depression, cognitive therapy is a first-line treatment, a very effective treatment, and this therapy focuses on modifying negative appraisals of self, the other, the world, and the future. Some other therapies include mindfulness-based cognitive therapy, but this is mainly effective for preventing relapse of depression in patients who are remitted, who have had a previous depression but are well. We don't know if it works for a current depression. And interpersonal psychotherapy, and I'll be talking about this therapy during this presentation. So, even though anxiety and depression are very common in people with Parkinson's disease, it's very surprising to find that there are very few studies that have, very few randomized controlled trials that have evaluated the efficacy of these therapies in people with Parkinson's disease who are suffering from an anxiety disorder or depression, or even anxiety symptoms and depressive symptoms. There are several small randomized controlled trials, as well as some uncontrolled pilot trials and case studies, which suggest that CBT may be efficacious for treating depression in Parkinson's disease. And some of the formats that have been evaluated include one-on-one CBT, group CBT, and home-based telehealth. So all of these formats have been found to have some efficacy for treating anxiety and depression in Parkinson's disease. And I think the home-based telehealth is very important because a lot of people, due to mobility issues, may not be able to attend the therapist sessions on a regular basis. So having this option for delivering care for this particular population, I think, is very important. There are no published trials of IPT, or interpersonal therapy, for depression, but I'm going to be showing you some pilot data that a study that I've been working on. And interesting, again, even though anxiety disorders are very common, there are no studies of randomized trials looking at cognitive behavior therapy for different anxiety disorders. But some of the studies that have focused on depressed patients who have anxiety symptoms show that CBT can also reduce anxiety symptoms. So this slide, and see how, well, it doesn't look so bad up there. This slide is a meta-analysis of randomized controlled trials for depression. This was published by Shi in 2015. And if you look at the, sorry, looking for the,
It's a red button.
the red button. Oh, here we go, okay. If you look at this part up here, which reviewed symptoms, which reviewed studies of CBT, The conclusion was that CBT is more effective than control conditions, with the standardized mean difference being about minus 0.90. What's interesting in these studies is that the control condition was often medication. So it is quite interesting that these meta-analyses suggest that CBT may be a little bit better than medication. Just to point out that many of these studies, though, are not very good quality. So the interpretation of these results have to be taken with some degree of caution. Now, at the bottom part, they talk about psychodynamic therapy. Now, even though psychodynamic therapy is not considered a first-line therapy for depression in Canadian guidelines, it is interesting that in the research that most of it has been done in China, found that psychodynamic therapy is very effective for treating depression compared to the control intervention, and seems to be somewhat better than CBT. So it's going to be interesting in future research to kind of compare psychodynamic therapy and CBT, because I think psychodynamic therapy is a very important therapy to look at. I'm going to talk a little bit about Roseanne Dawkins' study, because this is probably so far the best designed study that has looked at the efficacy of CBT for depression in people with Parkinson's disease. And this study included 80 patients, so it's a pretty big study, who were randomized to 10 weekly sessions of CBT plus clinical management or clinical monitoring alone. The CBT condition included 10 individual sessions of about 60 to 70 minutes duration. And the therapeutic strategies were very typical strategies that are used in CBT, such as thought monitoring and restructuring and behavioral activation, some relaxation training, worry control. They also included exercise because, again, exercise is very important for people with Parkinson's disease. It really has a very beneficial effect on their Parkinsonian symptoms. So I think it's important to have included that. And they also included 4 caregiver education sessions. And the purpose of these sessions was actually to train the caregiver to kind of coach the patient to be compliant with doing with the CBT homework. And so that was their role. So this slide shows the results of their primary outcome, which was the Hamilton Depression Rating Scale, which was administered by blind evaluators. And as you can see, there was no change over time for patients who received clinical monitoring, but there was a significant effect for patients who received CBT. And you can see the effect is very apparent even midway through. So in session 5, we're really seeing a huge drop in depression ratings. And this kind of continues at endpoint and at follow-up. And they looked at predictors of response, and having a caregiver who participated in the study was a strong predictor of depression reduction with CBT. They also looked at, conducted some secondary analysis and published a paper in 2019 that looked at the effects of CBT on diverse profiles of depressive symptoms in Parkinson's disease. And again, this looks at the Hamilton Depression Rating Scale. And you can see that CBT had a very marked effect on core mood symptoms. So this is depressed mood, loss of interest, suicidal thoughts, feelings of worthlessness, as well as anxiety. So you can see the second line right here. So anxiety symptoms and somatic symptoms and insomnia. I mean, the effect on insomnia was not so great, but anyways, all of the core symptoms were significantly improved with cognitive behavior therapy. This slide shows sort of the diverse profiles of depressive symptoms based on the Beck Depression Inventory. And as, there's a, Again, a very pronounced effect for negative attitudes. So this includes a cluster of symptoms such as suicidality, feelings of self-dislike, a sad mood, etc., and also performance impairment. So CBT really had a profound effect on both of those types of profiles of symptoms in people with Parkinson's. So let's talk a little bit about interpersonal therapy, or IPT. So IPT is a time-limited focused therapy for depression. Sessions usually are 12 to 16 weeks in duration. And this therapy is concerned with interpersonal life stressors that either predispose, precipitate, or perpetuate depression. And it builds on empirical evidence that interpersonal stressors influence mood, and that depression impairs interpersonal functioning. So there's this bi-directional relationship. So when bad things happen to us, so we're diagnosed with an illness and we can't do things anymore, or we're having relationship problems, this affects mood. And then when our mood is low, when our mood is depressed, it affects the way that we deal with those situations. So there is this bi-directional relationship. And IPT is grounded on attachment theory, so relationships are very important, and strengthening relationships are very important. So interpersonal therapy links depression to 4 interpersonal problem areas. Complicated grief, so prolonged bereavement following the death of a significant other. Interpersonal disputes, so kind of having ongoing struggles with a significant person in your life. Role transition, so this involves difficulty adapting to changes in life circumstances that are often unwanted, like being diagnosed with an illness. And interpersonal sensitivity and deficits, like social isolation and long-standing problems forming and maintaining a relationship. And the aim of IPT is to resolve these interpersonal problem areas and also strengthen social support. So that's really the main focus of this intervention. So why IPT for depressed Parkinson's patients? Well, Parkinson's disease, as I said, results in many losses: loss of the healthy self, loss of social roles. People have to stop working, loss of valued activities, and loss of future plans. And also the disease presents really significant challenges to the patient's social network. And we know that, caregiver burden can result in increased conflict, and this can fuel depression in people with Parkinson's disease. Also, focusing on strengthening social supports is really important for Parkinson's patients, because its treatment really is very stressful. And social supports are known to minimize the impact of stress and adversity. IPT is also well standardized for older people. And also it's really easy for clinicians to learn how to do this. So compared to CBT, which I think is a little bit harder to learn and to do really well. So this can certainly improve uptake in clinical settings. So we did a pilot trial of IPT for depression. The study was funded by the Brain and Mind Research Institute and the Institut de Savoir, Montfort. And the objective of this study was to evaluate the acceptability and feasibility of administering 12 sessions of interpersonal therapy to depressed Parkinson's patients. Also, we wanted to evaluate the feasibility of including a support person in the therapy process, based on research suggesting that including a family member or support person could improve outcome, and also to evaluate the efficacy of IPT and evaluate the need for modifications. So patients in the study were outpatients who had mild to moderate severe Parkinson's disease. They were on stable doses of dopamine medication. They had no significant cognitive impairment. They had to have a comorbid major depressive disorder of at least moderate severity, so a score of 15 higher on the Hamilton Depression Rating Scale. They had to live independently, be able to attend the 12 weekly face-to-face sessions. And they They were allowed to be on medication, on antidepressants, but they were included in the study as long as their dose was stable before they started treatment. Ooh, okay, I'm fine, thank you. And that their dose remained the same throughout the intervention. So 24 patients were referred from the Movement Disorders Clinic at the Ottawa Hospital. 9 were not eligible, so they did not meet criteria for a major depressive disorder or have a sufficiently severe depressive symptoms, or they were unable to attend the 12 weekly sessions, and 1 person we couldn't contact them. So 11 people started treatment. 5 men, 6 women. Average age was 64, and the mean age of onset of Parkinson's disease was 55. So we had some pretty early onset patients in our study. So when we looked at what kind of adaptations we had to make, well, minimal modifications were required. We did include breathing and relaxation or meditation techniques to reduce symptoms of anxiety, because anxiety is a prominent symptom in people with Parkinson's disease, so we thought that this would help them learn how to manage those uncomfortable symptoms of anxiety better. We also emphasized engaging in health-promoting behaviors, but they had to do it with another person, right? So the sort of the social context of it was very important. And also, we had to be flexible with scheduling the sessions. Even though IPT is 12 weekly sessions, this is not always possible for patients with Parkinson's disease. So we needed to be a little bit more flexible. Also, you know, when patients wanted to go away on holiday and they had an opportunity to go away, we couldn't say no, because we want you to live your life as fully as you can while you're still able to do all of these things. So allowing people, allowing some flexibility in scheduling the sessions, I think, was very important. We had excellent compliance with the therapy. 10 of the 11 patients completed all 12 therapy sessions. There was very high satisfaction with the study intervention, and when we looked at what was the most common interpersonal focus of the 4 foci, role transition was the most common, and that's not surprising because of all of the difficulty adapting to this illness. When we asked for the support person to participate, only 36% of patients wanted their support person to be involved in the study. One reason was that they didn't want to burden the support person. They felt already guilty about burdening them already, and they felt that having them come into therapy and hear some of the issues that they have been presenting with would just place further burden on them. So they really did not want that. And some of them just didn't want anybody involved. This was a chance for them to speak, with a therapist without, feeling uncomfortable if the support person was there and they might talk about something negative about the support person. And a couple of patients did not have a support person available to attend. So this shows the reduction in depression rating scales. Again, you can see a very nice decrease in depression beginning on session 6 and just continuing on to session 12. Similarly, this is the Beck Depression Inventory. So again, we see a very, very nice decrease in anxiety over time, with differences already appearing at week 12. So very similar to the study, the CBT study by Dobkin, who found that a significant symptom reduction midway through. This is the Parkinson's Disease Questionnaire, which is a measure of quality of life in people with Parkinson's disease. And again, we see a very nice reduction in improvement in quality of life following the 12 sessions of therapy. This looks at the interpersonal relationships scale, and there's 3 subscales: social support, reciprocity, and conflict. We found a significant improvement in reciprocity, not on the other subscales, although they were changing in the expected direction. This might just be due to the small sample size. So we submitted a grant to the Canadian Institutes of Health research, and we were fortunate to get funding. So this study is funded by CIHR and also Savoir, the Institut de Savoir Montfort. And this primary aim of this study is to determine if IPT is better than a non-specific control therapy in reducing anxiety symptoms. Secondary aim is to determine if IPT is better than the control therapy in improving quality of life, interpersonal functioning, and Parkinson's disease motor symptoms, and also to address the question of whether treatment gains are durable at 6-month follow-up. And some exploratory aims were to look at predictors and mediators of treatment response. So it's a two-arm parallel design, a prospective study comparing 12 weekly sessions of IPT versus supportive therapy, which is our control intervention that controls for non-specific factors that contribute to therapy outcomes, such as receiving attention from a therapist. We aim to randomize 80 people who suffer from mild to moderately severe Parkinson's disease and who have a comorbid a depressive disorder. We're also including a persistent depressive disorder, not just major depression, which we did in our first study. And they have to have a Hamilton Depression Scale score of 12 or higher. Assessments are done at baseline, week 6 and 12, and at 6-month follow-up. Efficacy outcomes, our primary is the Hamilton Depression Rating Scale that's administered by telephone by blind evaluators. And we have a whole range of secondary measures, including measures of interpersonal relationships and experiences in close relationships. So this is the study, the flow of the study to date. 58 have completed diagnostic assessments, 16 were not eligible, 42 were randomized. 2 did not start treatment after being randomized, and 40 have started treatment. And again, like our pilot study, we have excellent compliance for people who start the treatment. Except for one person who completed 9 sessions, all of them have completed 12 therapy sessions. So I think this is a real testament to the fact that patients really like this kind of therapy and find it very useful. In terms of baseline and clinical characteristics, so 27 men, 15 women, mean age 64. All are Caucasian, which is a problem because for generalizing results to other ethnicities, but we're happy with whoever comes into the study. Most are married. The mean age of Parkinson's disease onset is 56 years. History of suicide ideation in 62% of patients, so that's pretty high, with 12% having made a suicide attempt. Similar to some of the other studies, just a high frequency of comorbid disorders. Mainly, all of them were anxiety disorders, GAD, panic, social anxiety disorder, and specific phobia. And some patients actually had 2 or 3 comorbid disorders. So this slide shows the relationship between interpersonal relationships and baseline depression and anxiety and quality of life. When you look at the attachment anxiety and attachment support measured by the experiences in close relationships scale, we see that there is a positive correlation with self-report depression, self-report anxiety, and for the attachment anxiety, increased disability. So people who have attachment anxiety are just more depressed and experience more disability and more anxious. Same thing for the attachment avoidance, significant relationship with depression and anxiety. For interpersonal supports, a negative association, so the more supports they had, the less depressed they are. And for conflict, again, a positive association, so the more conflict there is in their relationships, the more depressed they are and anxious they are at baseline, and the poor quality of life they have. Now, I didn't break the code. The statistician said not to. So I'm just showing you the overall results of the overall sample. So it's not stratified by treatment. And so, because we just don't want to break the blind right now. But anyways, I just wanted to show you what we're finding so far. So this is combined, the IPT and the supportive therapy groups combined. Again, we see a very nice decrease in anxiety, in depression over time, with differences between baseline already showing at week 6 and at week 12. This is for the Beck Depression Inventory, same thing, a very significant decline in self-report depressive symptoms that are apparent as early as week 6. For anxiety, there was a difference between baseline and week 12. That was significant. And for the Parkinson's disease questionnaire, so the questionnaire of quality of life, we see a significant reduction from baseline to week 12. So in conclusion, anxiety and depression are very common in people with Parkinson's disease and really should be routinely screened. Psychotherapy may be an effective treatment option for the treatment of depression and anxiety, and IPT may be particularly well suited for depression, considering the relationship between depressed mood, relationship conflicts, and attachment security and loss. But more trials are needed to establish optimal treatment guidelines for psychosocial interventions for anxiety and depression and Parkinson's disease. So thank you very much.
So, bon après-midi. So yeah, today I'll be talking taking a bit of a shift for more physiological perspective of that heart-brain connection and mind and kind of physiology, going through biological rhythms from the perspective of the heart and a few other physiological systems. So there's been quite some work that's been done in the field of sleep and psychiatry, notably to try to find biomarkers of depression and sleep. And as most of us know, when we don't feel well, we don't sleep well as well, in most of the case. So what you have here is, I'll have it try it, yeah, are what we call hypnograms. So basically in little graphs showing the progression of sleep stages as the night progresses. And you have a typical example here in a healthy person, and this is, I guess, a bit of a textbook example of what we see in people with depression. So it's been commonly reported that we see reductions in sleep duration, increases in awakenings, increases in REM pressure as well, so there's more REM sleep, so that paradoxical stage of sleep, and typically it occurs earlier during the night in people with depression. And there's a reduction oftentimes in the deep recuperative sleep, so in those kind of stage 3 and stage 4 sleep, which is oftentimes toned down in people with depression. So that is all good and well, but we see more and more that there's a lot of inter-individual variability in some of these sleep markers, and also very poor diagnostic specificity. And so just to give you an example, here we used those little sleep watches to basically monitor people's sleep at home. And we followed a fairly large cohort of young people who were either healthy, so healthy controls, or who had anxiety disorders, depression, bipolar disorder, psychotic disorders. And what one of the most prominent thing that we found repetitively was that the sleep schedule, be it the bedtimes, or in that case the wake-up times or sleep offset, are typically higher later in people with these different mental disorders than in healthy controls. And so you can see that this phenomenon seems to be kind of occurring across these different diagnostics. Here what you have is sleep efficiency, so a metric of the percentage of time that the people are trying to sleep, that they're actually sleeping, so the actual total sleep time divided by the time that people spend in bed, for example. And so the higher the efficiency, obviously the better the quality the sleep is. And again, you can see like maybe a slightly worse sleep efficiency in people with depression, but overall lower sleep efficiency pretty much transdiagnostically. So basically, and this is also something that we've seen more recently in large meta-analysis showing that some of the sleep EEG profiles that we were thinking were linked to depression seem to be kind of occurring, emerging as well in other psychiatric pathologies. And so basically the quest is still on to try some biomarkers in sleep of depression. And more recently, we started becoming more interested in how the heart sleeps. So that was a bit of a bias. A lot of our sleep metrics, our core sleep metrics are based on brain activity, so the EEG. But we wanted to take a bit of a step back here and try to see, acknowledge the fact that when we sleep, it's not just the brain that sleeps, but the whole body. And of course, these different physiological systems are also interacting with each other. So we were thinking that perhaps there's more chances of finding biomarkers in terms of physiology of sleep for depression if we look at interaction between different physiological systems. Another reason why we think that sleep is perhaps a nice window to look at biomarkers of depression is that if we specifically look at the heart rate, we know that during the daytime, of course, your heart rate is going to be modulated by a lot of different factors, be them emotional factors, behavioral factors, cognitive. You're active, you're out there, you're processing, you're doing things, and all of that is going to have a major impact on your heart rate. Whereas during sleep, most of these factors are not as influential. And you've got more space for the endogenous interactions between different physiological systems to kind of kick in and emerge. And so Maisa nicely presented this morning some of our results using, I don't want to recap everything here, but just the main message is we used in a large sample of people with depression versus healthy people, and just by looking at heart rate during sleep and using machine learning techniques, we've been able to identify with a very high accuracy who is depressed and who isn't. So that kind of suggests that there is something in the heart rate profile during sleep that is so altered by depression that it could be a viable biomarker of depression. But as most machine learning type of techniques, this kind of remains a bit of a black box. We know that what we feed in the machine, we know what comes out, but what happens in the middle, what does it mean from a physiological perspective? This is some of the work that we're currently doing to try to understand that relationship a little bit better. And one of the things that we started doing is to look at heart rate variability during sleep across different sleep stages. And here what you have is some results in a very clean kind of subset of our sample. So these are people with depression who do not have any other psychiatric comorbidities or cardiovascular comorbidities or sleep comorbidities. They are not medicated, and we ensured that they spent enough time asleep as well. So what you have here is the SDNN, basically a metric of general heart variability of the heart rate during either wake, non-REM sleep or REM sleep, so that paradoxical stage of sleep. And I'm sorry, that kind of cut off, but the blue line is the controls, and the red line is our depression group. So what we see, if we focus on wake, we're kind of replicating a little bit what has been done before in wake studies, so that there's this kind of reduction in heart rate variability in people with depression. But this seems to be increased quite significantly in the sleep state, and especially in non-REM sleep. So kind of suggesting, again, that sleep might be a very nice window to see some of the abnormalities in the heart rate emerge more prominently than what we can see during the wake state. Another thing that we started to do is to look at the temporal dynamics of heart rate across the sleep period. And so typically, what you have, as you might, that's quite intuitive, during the daytime, in a healthy person, you would see a lot of variations in heart rate as we go on with our daily activities, but then during sleep, we see a sharp drop in heart rate, and that remains fairly low during the whole sleep episode, and that it then increases in the morning to resume to our daily values. What you have here on the right side are exactly that, but this is real ugly data from some of our studies. So we have 3 different individuals who are basically healthy people, and you can see a bit of variation, which is probably linked as well to sleep stages, so the REM and non-REM cycle, but basically generally overly flat kind of progression of heart rate across the night. And what you have here are 3 examples of people with depression, and you can see that the profile is quite different. So we see this kind of progressive reduction in the heart rate as the night progresses, which is quite different than the controls. And I just wanted to give you some concrete examples here, but we've actually recently done statistics on a sample of 150 patients with depression versus healthy controls, and found that the slope, if we just do a linear kind of model fit on the progression of heart rate across a sleep episode, we see that the slope of decay is significant here as compared to our control group. So that might be one of the different factors that kind of contribute to depression having this very specific profile of heart rate during sleep. I want to talk a bit about blood pressure because we know that it's quite heavily influenced by sleep as well. So this is some of our earlier work, basically showing in the group of elderly people and young adults. You have here systolic blood pressure, diastolic blood pressure, and the heart rates in a normal sleep condition versus in a sleep deprivation condition. And you can see that the sleep deprivation basically led to a significant increase in blood pressure, especially in the elderly people. And so those were healthy people, so and I would say even super healthy people. So you're kind of not typical elderly person without any kind of medical problem, no medication, no nothing. So kind of superheroes that were all normotensive. And just with one night of sleep deprivation, we brought them to the hypertensive or pre-hypertensive level. So that is just to show the kind of the importance of sleep for cardiovascular, for blood pressure. And it's not just blood pressure per se, but also blood pressure regulation. So I want to just show you here, basically you've got, on that first top line, you've got blood pressure in a rested condition, and the lower lines are sleep deprivation condition. But here you have blood pressure in a semi-recumbent position versus after standing up. So really that basically we put people through an orthostatic challenge, just taking their blood pressure while they're sitting, and then again after they stood up. So typically what you'll see is in those conditions is an increase in heart rate to compensate and maintain blood pressure to similar levels. But in a lot of people we'll see a slight decrease in blood pressure after standing up. So this is kind of what you see here in the sleep condition. But basically sleep deprivation toned down that effect as compared to the sleep condition. And so basically the main message here is that sleep is not just important for blood pressure, but also it's kind of ongoing regulation. And we started doing that as well in a cohort of patients who are referred to the sleep clinic at the Royal. So these are mostly people with suspected sleep apnea. And what we did was to give them a little sleep watch so that we can measure their sleep at home before they come to the clinic and get the full assessment with their sleep doctors. And we took their blood pressure. We basically used the same type of protocol whereby we took their blood pressure while they're seated and then after standing up. And here what you have, and these are just fresh out of the oven type of results, but what you have is a correlation between the total sleep time and the orthostatic response in heart rate. So basically, those shorter sleepers were those who had the wider increase in the heart rate after standing up. And we see a similar profile in blood pressure. So rather than blood pressure basically going a little bit down or staying stable after standing up, we see that those with the worst sleep profiles actually had an increase in blood pressure. And what I've put in yellow here is kind of the criteria that are used for orthostatic hypotension, so that abnormal kind of profile of reacting to changes in posture that is fairly rare. We see more often orthostatic hypotension. So the hypertension is a little bit more of a rare disease. But it seems like those people with sleep apnea who get the less sleep tend to have more of that profile. But again, these are very preliminary results. So I want to talk now a bit more about other types of rhythms, so circadian rhythms, which are on a longer period, basically regulated by our biological clock in the suprachiasmatic nucleus to orchestrate a range of behavioral and physiological functions across the 24-hour cycle. And one way to look at it from more of a behavioral and psychological perspective is to look at chronotypes, which basically reflect people's preference at which to go to sleep, go to wake, or do different types of activities. And we basically measured that in, again, across different diagnoses of mental health. And we found that there was an overall shift towards later chronotypes, and that was associated with worse psychological distress and worse depressive symptoms in those with depression or bipolar disorder. And the interesting thing is that we followed these people over about a year and a half, and we saw that there's a subgroup who shifted towards earlier chronotypes, and those were actually the ones who also showed significant improvements in terms of their depressive symptoms. So suggesting that there might be a relationship between clinical changes and changes in chronobiology. And if we dive in more biological markers of circadian rhythms, this is to give you an example of the type of measures that we're collecting in the laboratory, and also the types of kind of variation that we see over a 24-hour period. Here you have the rhythm of core body temperature, which typically drops in the middle of the night towards the later portion of the night. Whereas hormones like melatonin, sorry, the colors are inverted here, but melatonin will start rising and reaching a peak during the sleep episode, but typically the important part is that period here where it starts rising before sleep to enable people to fall asleep better, because melatonin is a soporific hormone. And so what we've been finding in young people with depression is that rhythm of melatonin is shifted later, and actually in some cases so late that melatonin doesn't start rising before the people are actually asleep on their regular schedules. So that by the time that they hit bed here, it is very difficult for them to fall asleep because their brain is not flooded with that sleepy hormone. And what you have here is basically the sleep schedule, the mean sleep schedule, so with sleep onset and sleep offset, so the time at which people woke up, and the midpoint of the sleep period, the time at which melatonin starts rising, and the time at which core body temperature reached its minimum. And what we've done here was to use data-driven approaches in our wide sample to try to isolate subgroups of people with depression with consistent chronobiological profiles. And we found two main groups. One group that had a conventional kind of circadian profile, and one group that had a delayed profile. And in the delayed profile, we saw that there was this massive delay in dim light melatonin onset, as well as in core body temperature. And there was also a delay in sleep onset and sleep offset, but that was milder. So basically, because the different biological rhythms didn't shift in the same direction to the same extent, we see a disorganization of the temporal alignment across these different markers, whereby the angle, if you want, between the sleep-wake cycle and the core body temperature was extended, and the angle between melatonin and the sleep period were also shortened. And importantly, that was linked to depressive symptoms profile. So if we looked at, here you have the Hamilton Depression Rating Scale and all its subscales in the conventional group in light blue and in the delayed group in dark blue. And you can see that there's this significantly higher depressive symptoms overall that seems to be kind of linked to, more specifically, to the depression subscale independently from the sleep subscale. So that seems to be not driven just by sleep. And very interestingly, we saw this higher rate of also subsyndromal mania or hypomania symptoms in those people with the delayed sleep profile. And that's something that kind of came up across different subsets of our samples. And here I just wanted to show you quickly some of the neurochemical correlates of these chronobiological abnormalities. So myoinositol is a glial marker that we know is potentiated by melatonin, and we also know that there are some studies that show that myoinositol is lower in people with depression, especially in frontal cortex. So we basically here found a correlation whereby those who had the worst phase delay in melatonin also had the lowest level of myoinositol. And so all of that, those abnormalities that we're seeing in people with depression in terms of chronobiology and sleep kind of lends itself well to think about treatment and interventions that would be sleep-based to enhance mental health. Here, that's the study that we did in Sydney using an melatonin agonist and serotonin antagonist that unfortunately is not available here in Canada, but we basically were interested to see how that would play in terms of not just depressive symptoms, but also chronobiology. So we after 8 weeks of treatment, we saw this nice decrease in depressive symptom severity that was paralleled by a phase shift to earlier melatonin rhythms, and the two were actually nicely correlated. So we've seen that depression is closely linked to abnormalities in sleep and biological rhythms, but there's a lot of inter-individual variability, and so I think that there's more work to be done to understand these different profiles and how they may be amenable to different types of sleep interventions. And light therapy is a nice example because we know it works very well, for example, in people with seasonal affective disorder, but if we look at people with your regular depression, the effects are very inconsistent across individuals, and so one of the things that we're currently doing is trying to understand who might respond better to these types of treatments. So here you have, we're using these glasses that we're lending to patients to use at home in that case, for 4 weeks, and we see this progressive reduction in depressive symptoms, which is good, but the important part is that those who responded better, so those who showed the widest response in terms of depressive symptoms, were those who presented the worst sleep profile to start up with. So just based on questionnaires, people who indicated that they had trouble falling asleep or that they had poor sleep quality, that they had intrusive thoughts as they were trying to fall asleep, were those who really showed the widest improvement. So here we go with an easily identifiable marker that we can use to try to orient people towards this type of treatment. And interestingly here as well, we see this progressive, kind of correlation between improvements in sleep and improvements in depression severity along the course of treatment. And I wanted to touch base as well very quickly on sleep-related breathing disturbances. So on the top, you've got here an example of a sleep apnea. So that's when people stop breathing during their sleep. And that happens very often, several times during the night. So you can imagine what type of damage this can cause to the brain as it lacks oxygen repetitively across the night after night. And what we've done here is just basically look at these indexes of sleep-related breathing disturbances in a sample of young people with treatment-resistant depression. We were very surprised to see that 55% of them had signs of clear sleep apnea, and that was undiagnosed. And here, perhaps more importantly, you've got that correlation between the severity of the breathing disturbances during sleep and the severity of the persisting symptoms despite treatment, kind of suggesting that perhaps people were not responding to your classical antidepressants because there was still that problem that remained unaddressed in terms of the sleep apnea, which can lead to also depressive symptoms. And I guess the tricky thing here is to actually spot that sleep apnea is there because it's an insidious disease. A lot of people don't know that they have it, so I believe that there's more work to do to raise awareness about it and finding methods to screen it and treat it, because that's the great part about it. We know that sleep apnea can be readily treated with non-pharmacological interventions, and that typically leads to improvement in depression as well. So to just summarize very quickly, we've seen that there's autonomic dysfunctions that are linked to depression that might be actually worse during the sleep period, and over time that might contribute to the poor cardiovascular outcomes that are linked to depression. We know that there's heart rate profiles during sleep that might be potential biomarkers for depression, and we're currently investigating how specific they might be to depression as opposed to other mental disorders. There's a subgroup of people with depression who may have more pronounced circadian disorganization and circadian delay that might be amenable to some chronotherapies, as we call them, or therapies that are really focused to realigning the biological clock. And we have promising evidence to suggest that this might lead to a better clinical profile as well. And so that's one of the next steps that we're currently taking, because a lot of these studies that I've presented were done in the lab in highly controlled environments and with fairly expensive types of measures, but now we're seeing this explosion of ambulatory devices that people can wear in the field, which I'm actually wearing right now and nobody notices, but we can track people's heart rate and people's sleep at home, temperature, so we're looking at integrating these various signals in a model that which hopefully enable us to predict the onset of depression or the onset of manic episode, as we can feed those through like smartphone. And hopefully the end game would be in a couple of years from now to develop some predictive applications that people could use to self-monitor and try to see episodes coming. And on that, I'll stop there and thank you.
Yeah, thank you very much. So maybe put it this way, yeah. So I'm yet another psychiatrist who steps down from the brain to the heart because the cardiologists don't dare to step up from the heart to the brain. So there we are. So, and I want to basically make you a case how important this sort of interaction is. And unlike Rebecca, I don't focus on sleep, I focus on the awake state. So let me see how the... Is this one, or which one works here? This one? Yeah. Okay, let me start. I'm not fully sure here. No. Which one is this?
It's the one that you
this
had.
one?
Yes.
But that doesn't work. Ah, there it is. Okay, good. So very, very briefly, brain and heart are connected in multiple ways, and that has become more and more clear in recent research. First, there's a direct connection from the heart to the brain, because, and I will show you data later, that the heart heartbeat is directly processed by the brain in various ways in multiple time scales. So there I set the tone. It's all about time in my talk. And however, there's also the... this is really difficult. Okay, there it is. The other way, it's also, as you probably all know, that the subcortical regions of the brain and the tense cranial nerves controls the heart from the brain, controls the heart and its activity, autonomous nervous system, sympathicus, parasympathicus. And there has also been a lot of exciting research recently, in recent years, that there's a lot of vascular metabolic connection. I mean, that goes by itself because unfortunately or fortunately, the brain is dependent upon the heart for the blood and all the metabolism, otherwise we can't do anything up here. However, there's also a lot of endocrine, neuroendocrinology going on, a lot of neuroimmunology mechanism, and these are also relevant for psychiatric disorders, but I basically glance over that because the main focus is, as the title of my talk, the tango. Tango is about two people dancing together and trying to synchronize. Yeah, and they have to synchronize in the immediate moment, in the short term, as well as over time. And that kind of synchronization, there's more and more evidence, also goes on between brain and heart. And I show you some of that in my talk. Has mainly 4 parts. First, I want to show you from the clinical side that there's a lot of evidence from both sides, cardiology and psychiatry, that is really a lot of overlap, symptomatic. The second part, I will briefly go into some of the mechanism, particular temporal mechanism connecting brain and heart. Third part, then I will show you some of these mechanisms are abnormal in brain-heart abnormal and brain-heart disorders. And then I show you an initiative at our institute in conjunction with the Heart Institute that we establish a brain-heart registry at our brain imaging center at the Royal. So let me start with the first part, clinical evidence of brain-heart connection in psychiatric and cardiac disorders. So one typical symptom which every psychiatrist knows, but probably also many cardiologists have seen that in their patients, and it was discussed this morning, depression. And when I talk about depression, I don't mean just the momentary depression, but really the depression which you cannot avoid going to the psychiatrist, whether you want it or not. Yeah, and you see this kind of depression in what we call in the psychiatry major depressive disorder. And interestingly, these patients have a lot of somatic symptoms, stomach, various other bodily abnormalities, and also strong cardiac symptoms. Subjective perception, that they have the feeling their heartbeat beats too fast or too slow. And also objective, they have a higher incidence of coronary artery disease, myocardial infarction. So it's really, there seems to be already here, from the psychiatric side, major depressive disorder, a close connection with the heart. And I remember when I worked back in Germany as a resident, we had a lot of Turkish patients, and these patients expressed their symptoms very differently than the Germans, or here also the Canadian patients. Here the patients are much more cognitively in their depression. The Turkish patients were much more somatic. So we often thought they initially had personality disorders because or histrionic, but it turned out to be a major depressive episode. Yeah, and we called it morbid Turkey at the time. Yeah, so there you tell the somatic symptoms are really important. I remember one patient actually, she went through for 6 months through the various departments of internal medicine. Nobody could give a diagnosis, and you know what happened when the internal medical doctors can't give a diagnosis. Then they finally called the psychiatrist. And that's exactly what she had. So we treated her 3 weeks with antidepressant, and whoops, the depression disappeared. And this was mainly somatic symptoms. Yeah, so it's really amazing. Then yet another psychiatric disorder is here. I indicate that by the famous painting by Edvard Munch, are anxiety disorders. So anxiety disorders are a mixed bag. We assume, among others, generalized anxiety disorder, social anxiety disorders, panic disorder. panic disorder is particularly dramatic. The people usually end up in the emergency room and have the feeling that their heart is getting crazy, that they get a myocardial infarction, and then of course everybody is up in arms. All the cardiologists can't find anything. So what happens? Call the psychiatrist. Yeah? And you just give some lorazepam, some benzodiazepine, and 5 minutes later patient is calm. Yeah? And if the psychiatrist experienced, she or he knows what's going on. And so again, I said there's strong cardiac symptoms, panic disorders, they're really the light symptom. In the other social anxiety disorder, if you don't want to speak in front of public, you're afraid, of course, you have subjectively, you have the feeling that your heart is racing, you might feel even palpitation, chest pain, mimicking the symptoms of myocardial infarction. However, this is not only the psychiatrist patients show cardiac symptoms, it's also the other way around. So I'm working now closely together with the Heart Institute, and the more I work, the more it comes out that, for instance, these three group of patients, and this morning you heard it, atrial fibrillation, coronary artery disease, myocardial infarction, also can show very much anxiety and depression, which impedes their life quality. And again, it's also here a matter of treatment, because some of the antidepressant treatment we give can have cardiac side effects. So that's exactly the opposite of what you want to have. So it's really also here, we needed new forms of treatment which are more mechanism-based and less subjectively and objectively side effects. Yeah? So that, I think, really makes a point. So there must be an overlap mechanistically, and that's the second part of my talk. What are the mechanisms? How do they communicate with each other? And how do they align each other? So again, as I said, I always compare it to 2 or 3 people or many people dancing. They synchronize with each other. And the synchronization is completely unconscious, obviously, in dancing. Yeah? The good dancer does it completely by default, unconscious. These are default mechanisms which you have no voluntary control over. And exactly these mechanisms are altered, apparently, and that's what we want to show in these disorders. Yeah? So let me get a little bit into this. So one way is you can measure, and again here, to the delight or the dismay, the psychiatrist approaches the heart rate variability again, because it's really the mechanism, particularly on the temporal side of things, heart rate variability. And again, like Rebecca, we consider the heart rate variability sort of also in a longitudinal sense. So here we applied an analysis of sliding windows, 30 seconds, sort of a dynamic heart rate variability. Why do we do this? Because we can measure analogous 30-second windows in fMRI. We use fMRI here because we want to get some of those regions where the coupling between brain and heart, where the cardiac input is particularly strongly processed in the brain. And that's really the fMRI is the main technique for doing that. And however, the temporal resolution of fMRI is rather low, so you have to do sort of a longer time windows. And what we do here, that we really have equal sliding windows, 30 seconds, and again, like here, like the heart rate variability, the distance between the 2 subsequent RR peaks that we here basically measure the variance of the electrodes. The amplitude, sorry, not the electrodes, the variance of the amplitudes, yeah? And then we really have sort of methodologically we operate in the same sort of time window / the 30 seconds. And regions which are really targeted is really somatosensory cortex, very typical. No wonder primary and secondary somatosensory cortex. Here I show you yet another region, very interesting actually. So here you see the raw bolt signal, the fMRI signal. Here you see the amplitude, the variation, standard deviation of the bolt. And here basically you see the standard deviation of the RR peaks / the heart rate variability. And then we can really trying to see whether there's a relation, and we can have various methods of correlation, regression, and linking them to each other. And indeed, that has been shown in these regions. So here's the ventromedial prefrontal cortex. This is very interesting because this is a region where when you're not interested in my talk, you're just dwelling away in your own thoughts. I hope I make you awake now. So that's a region that is very active when you don't listen to me and say, oh, you think about your nice evening dinner or whatever. Yeah. So there's no escape from a psychiatrist, as you know. So that's basically, and so this is really, it's a region which we often associate with the sense of self. This is very interesting. And indeed, so there seems to be a close connection between your synchronization with the heartbeat and your sense of self. I will come back to that because this is very relevant for the psychopathology in the psychiatric cardiac disorders. And another one, obviously, is the midbrain. I don't need to tell you that everybody knows this from the anatomical studies. Deep down in the subcortical regions, typical, some people describe it as an autonomous central autonomous network down there, and obviously there's also strong heartbeat regulation. Another region which I didn't point out is, but you can see this here, is the insula, where there's a lot of convergence between external input from the environment and the internal input from the own body. Yeah, so that's why you often in your perception also link these two. Yeah, so that gives you sort of an idea about how, let's say, over longer stretches of time, brain and heart are sort of aligned. And I show you here sort of the frequency ranges. This is very important. If you do these studies, if you want to link the two, you have to operate methodologically in similar frequency ranges. So you have to see the same frequency range here in which the heart rate variability operates here between 0.01 and 0.5 hertz, and this is exactly the same frequency range where we also operate in fMRI. So meaning, to put it more easily, you have to adapt to the same rhythm or to the same time scale. Yeah? That's very important, because otherwise you compare apple and oranges. That's what you don't want, because it's heart and brain. However, so that's sort of more over longer term, and we call this temporal spatial alignment in the recent review paper. However, there's also very immediate. So when you dance, you have to synchronize over longer time intervals, you have to align, but also in the immediate movement, each movement. Yeah? So that's where we come into a very short time scale, into millisecond. And that's exactly, and this is very interesting. There you can see here, so I show you this. So here you now move from fMRI into EEG, or here we did show MEG data, magnet encephalography, which has a much better spatial resolution than EEG. And what you can interestingly observe, so here we plotted the EEG, and particularly the R peak. So the R peak is central for us. Without the R peak, we can't do anything. And we take that basically as stimulus onset and see at that time point what is the what is the brain doing? So that was a Freudian lapsus here. So what is the brain doing at that time point? And you can see here we picked out three main regions: the insular somatocentral cortex, ventral medial prefrontal cortex. It's the region when you now don't listen and think about your next appointment. And you see at exactly the time point of the R peak, you have sort of an evoked activity, as we call it, or heartbeat evoked potential. Yeah? So there's a very fine temporal tuning between the R peak and the corresponding neuronal activity in the brain. And you can see here, up here, also sort of it moves across the different regions of the brain. Yeah? So probably the whole brain is sort of involved in processing this continuous input, because the brain, for the brain, is just a perturbation. The brain just needs to integrate and attenuate the impact of that. Yeah, and the better the brain integrates this continuous perturbation, the less side effects of that. Yeah, and even more interesting, where you can really say the brain has continuous fluctuations in different frequencies. So the amplitude continuously fluctuates in different frequencies, faster and slower. And this is sort of phases, up and down phases. We call them peak and trough. And you can see that the brain is very flexible, because it locks its phase onset to the onset of the heartbeat. So in the same way, you lock your movement of your right leg to the movement of the left leg of your partner. I hope I got it right. Yeah. And that's exactly what you can see here. You can see again the R peak, and here you can see the phase onset. So it's the phase concentration that is always the same part of the ongoing phase locked to the heartbeat, to the R peak. And you can really see this is particularly in the delta range, as we call between 2 and 4 hertz. And that has a duration which corresponds exactly to the RR interval. I don't need to tell you that. So there seems to be a correspondence between the duration of the phase fluctuations in the brain and the duration of the RR intervals. So that's basically the brain matches a corresponding timing on its side to the timing of the heart. And then you can see this sort of, we call this intertrial coherence or phase locking factor exactly to the heartbeat. And remember this picture because it will become very important later. So you can see basically, I don't very briefly go into this, only here you can see different measures. You can have neuronal variability, heart rate variability, intertrial coherence, or this phase locking, or the heartbeat evoked potentials, where you can really describe the alignment, more longer term, and the more short term synchronization between brain and heart. So now I come to some of the abnormalities, the clinical side, how you can link this to symptoms. And interestingly, I showed you that different regions and also particular networks here, the ventromedial prefrontal cortex, I mentioned that this region here, this is part of what we call default mode network. And I already mentioned that that network has a close association with our sense of self. Indeed, there have been studies shown that the neurocardiac coupling of the processing of the heartbeat in the brain in exactly this network is also directly related to your sense of self. Then the somatosensory motor, somatomotor network, somatosensory network, you can see it here. I already mentioned that primary, secondary somatosensory cortex has something to do, also the coupling here, neurocardiac coupling, closely associated with the awareness of your body. And I mention all these presumably strange mental features for you because you will see in the next slide they will resurface in terms of symptoms in these disorders. And then another networks, I mentioned the insula. It's the core region of what we call the salience network. And the salience network and the coupling between neural and cardiac activity in this network has been associated with emotions. Now, interestingly, when you look, for instance, I make here the case of anxiety disorders. In anxiety disorders, so panic disorder, generalized anxiety disorders, you find a decrease in the default mode network activity. And you also find that hasn't been associated yet with abnormal brain-heart coupling, but it is known that the heart rate variability is abnormal, mostly reduced, less variable in these anxiety patients. And interesting what you see clinically, their sense of self is completely limited time-wise. They're not able, they're completely locked to this subjective perception of their heartbeat, palpitations, chest pain, and so on. They're not able to put this into temporal perspective. So then, interestingly, in particular panic disorder, you find an abnormal increase in activity in somatosensory network. We had several papers on that, and others confirmed that. And that is related to an abnormally strong perception of your own body. So you're abnormally sensitive to any kind of sensation. So usually if you have a slight arrhythmic heartbeat, which you usually would not even perceive, but now because you're abnormally sensitive, you perceive this, and then of course you become threatened. Yeah, you become anxious because you can't control it. And finally, salience network, I told you, is associated with emotions. And again, you find an hyperactivity in the insula, particularly the insula in these patients. So that probably heightens your awareness and also gives you abnormal emotions. That's exactly what you see in these patients, anxiety and fear. Yeah, so I forgot that. That is really, the neurocardiac coupling. Now, let me go to the next one, and then I present this afterwards. So here, it's a very first start. We had one patient with atrial fibrillation, so we came now from the other side, cardiac side, and he suffered from depression and anxiety. This is our first patient from that side. And here we could, here we measured the heartbeat evoked potential. You could see the typical potential here. This was now EEG, pure resting state. Here is the R wave, which we didn't show here, but here is the onset of the R wave. Here you see sort of the topographic map. Here you see the heart rate variability. What you see here, this is the patient. He has a slightly larger amplitude in the heartbeat evoked potential. There's some differences here, heart rate variability plus minus the same. However, the really interesting finding may lie in here. So remember, this was what we described, sort of where the brain locks its onset, its phase onset, to the onset of the R wave, the heartbeat. And so it shifts in the same way you shift your right leg always according to the left leg of your partner during the dance. In the same way, and sort of you see a phase, what we call phase concentration or phase locking or intertrial coherence, here again in the lower range between 2 and 4 hertz. This is a healthy subject, and you see, this is very encouraging, in the patient you see much less phase locking. So apparently his brain is not able as well to lock its phase onset to the heartbeat onset. It's no longer as flexible. So there is some desynchronization in the dance between the two partners. And then if it becomes too large, of course, maybe one of the partners become anxious that the whole dance, the whole tango falls apart. And same here. So this now we want to do more patients on this. So this is very encouraging. Now let me go back to this slide. Remember I showed you first these fMRI data where you had longer time windows, 30 seconds and longer. fMRI lasts about 5-6 minutes, where you have these longer time windows, and maybe that if you have a misalignment over longer time windows, that the variabilities of the heartbeat and the brain no longer match with each other, that then maybe you have rather what we call in cardiology a permanent or persistent atrial fibrillation. So it's maybe more a long-term mechanism on a longer time scale. Whereas if you have paroxysmal atrial fibrillation, maybe your neuronal variability matches quite well with each other, but maybe your intertrial coherence, that you can't shift the phase onsets sometimes properly, and then you get a bout of anxiety, and that's what we call then paroxysmal atrial fibrillation, and then with corresponding depression and anxiety. So this is something, so you see that some of these mechanisms, which looks very abstract, they might translate and map quite well with some of the clinical phenomena we see on both psychiatrics as well as cardiac side. So let me come to the fourth part, last part of the talk. So because there's a lot of intercommunication between brain and heart, and also because our institute is very close to the Heart Institute, so we said, okay, why not establishing a real brain-heart registry, meaning that we get cardiac as well as psychiatric patient and healthy subject, that we scan them with a regular protocol, combining brain and heart. So let me illustrate that briefly what exactly we're doing there. So the main idea is really to go into some of the mechanisms, vascular mechanisms, metabolic mechanism, and the kind of temporal mechanism I just described in the coupling between brain and heart. And ultimately the idea is really to find some diagnostic or therapeutic predictors of depression and anxiety in cardiac disorders, as well as of cardiac symptoms in psychiatric disorders. Yeah? So, and I think this is a very unique, as far as I can see, really worldwide unique initiative, because it links basic mechanisms with direct clinical application. And it is, every cardiologist probably among knows, it's a big problem how to treat the depression and anxiety. And vice versa, it is a big problem for the psychiatrist to treat the cardiac symptoms, whether they're subjective or objective. It doesn't matter, because they impede the patient's life quality severely. Yeah? So it doesn't matter. And ultimately what we call subjective, where you say as a cardiologist it's just psychogenic, this is for the psychiatrist. From your part it is because it's a normal heart rate variability, but there's something wrong in the brain. That's what I wanted to indicate with these findings. So it has a neuronal basis here. So why? So the idea is that everybody who goes through the scanner, research-wise, will be asked whether she or he consents also to do a separate investigation for the brain-heart registry. And also, we are open, this is also to external partners who are interested in having their patients or subjects scanned in this way. We can open, and we have a research coordinator for that, and we are very open to have different kinds of groups, because these kinds of phenomena are also very relevant in stroke patients, in the rehabilitation of stroke, and so on. Yeah, so the idea is, as I said, large sample of healthy psychiatric cardiac sample. I already said that. And everybody has access to the data, so everybody can request the data, and independently of the stored of the respective PI data. So this is a common initiative of the Brain Imaging Center at the Royal, of the Institute of Mental Health Research, and the Heart Institute. Who basically, I already said this, all healthy subjects undergoing cardiac scanning, all cardiac subjects, you see here below, whatever diagnosis, all psychiatric subjects. So what we are really interested here, we pursue really a dimensional or syndromal approach independent of the disorder, because that is, we're really trying to look for the correlates of symptoms and biomarkers, diagnosis and therapy of specific symptoms, because this is what you treat as a clinician, and where we really lack proper mechanism-based treatment. And for instance, I give you one idea, which sort of we are trying to establish, that when you really have a desynchronization with this phase locking, we might use some stimulation techniques then sort of to resynchronize the neuronal activity to the heartbeat. Yeah? And so, and that could be directly therapeutic intervention. And I think, so everybody who is interested in this, we are also open to outside collaboration. If you want to send patients from different disciplines, we're very open to that. You can contact me, and I don't need to tell that I see this as an answer, and thank you very much.